And we are going to get started with chapter 17 this morning. I did cover some of this uh, patho in the beginning of the chapter with you guys in class, but I just want to recap on a little bit of it so that you remember. Okay, so remember, anywhere from the mouth to the anus is going to be part of that digestive system. This is where your food is going to be broken down. We have that mechanical digestion taking place there that starts in the mouth. Remember, said that started with salivary amylase. That's going to break down those carbs in the mouth. You have some glands up there, okay, that are helping to secrete different substances. And you also have your stomach. Your stomach will secrete things like mucus, hydrochloric acid, and also the precursor for pepsin. And this is going to help break down the proteins. So things that you're going to really have to know for this chapter is what causes things like peptic ulcer, what causes the foods to be broken down, how are those foods broken down, what organs are responsible for those foods being broken down. Now, you know, there's a lot of hydrochloric acid released in the stomach that's responsible for helping break down the pepsin and the proteins. Okay. And then let's talk about some of the structures just a little bit. You have the duodenum. That's the first part of your small intestines. And remember, I said that food is slowly being released into that area. And that's happening through the pyloric sphincter. And it just goes in there slowly, a few mLs at a time, so that the body can keep up to it with it to absorb the nutrients that it needs. So the food goes in the duodenum through that pyloric sphincter. You also have the jejunum and the ileum. And the ileum is responsible for what?
Is it
You guys know?
peristalsis?
Uh, absorption. Okay, that is your main area of absorption. So if you see a question, it'll either say to you, what's the main area of absorption? And it might list the small intestines, which is true, but specifically the absorption process is really taking place in the ileum. Okay, and then you also have the jejunum there. These are all part of the small intestines, and they're responsible for the absorptions of fats and nutrients. All right, so basically everything I just said, okay, that the digestive system is doing is processing what we eat and drink, breaking it down. It's controlled by these different enzymes, some of which we're going to talk about. It helps with absorption. Okay, you have a lot of different parts, and they all do different things. We're going to talk about them as we go through the slides. Okay, in the gut, you have mucosa. That mucosa is basically protecting the lining of your stomach. Okay, there's a few different layers there, and there's a rapid turnover rate there with the cells because there's a lot of wear and tear going on along with the food and secretions moving through the tract. There's also a submucosal layer that's going to have your connective tissue, your blood vessels, your nerves, the lymphatics, and those glands that secrete those different enzymes. You have smooth muscle there. Remember, when I talk about smooth muscle, I always say smooth muscle involves some sort of action. So that smooth muscle is transporting food and fluids. So it's responsible for motility. And then you have an outer layer. Okay, this is the peritoneum. It's called the visceral peritoneum. And this is a large serous membrane. Okay, and that is going to form the visceral peritoneum that is going to surround the organs like the stomachs and the intestines to try to protect them and help them move, help them glide. There's a lot of pain receptors in the parietal peritoneum, and those pain receptors are connected to spinal nerves. Now, we talked about spinal nerves in the past and how they're connected to different parts of the body. And when there's damage to those parts of the body, they help us connect and determine where that damage is or really what's going on in the body. It kind of helps us pinpoint a specific area. The peritoneal cavity is the space between the parietal and the visceral peritoneum. There's a small amount of serous fluid there. I just talked about what that fluid does. Remember, it's helping to guide or facilitate the movement of the structures in that area. All right, so next up is the oral cavity. This is where the beginning phase of mechanical breakdown starts to take place for digestion. Your teeth are going to chew and break down the food and mix it with saliva. We call that mastication. There are salivary secretions from the parotid, the sublingual, and the submandibular glands. Okay. Sorry, saying all those words 3 times in a row can sometimes be a little daunting. All right. So these salivary secretions from the parotid, sublingual, and submandibular glands are going to enter the mouth through ducts called salivary ducts. And this is going to help to moisturize and lubricate not only your mouth, but any food that's passing through there because otherwise it'll be dry. And if you can imagine just taking a handful of saltine crackers, crush them up and stuff them in your mouth and try to swallow it, that's what your mouth would be like if you didn't have the production of this saliva. The saliva also has amylase that is going to start the digestion of carbs in the mouth. When the food's ready to be swallowed, your tongue is going to create this bolus and it's going to push food, okay, this bolus of food back to your pharyngeal wall. And then there are nerves there, your trigeminal and your glossopharyngeal nerves. They'll send information to your swallowing center. And you know that that is located where?
The medulla.
Yes, in that medulla. Good job. Okay. And the reflex there is now activated, and that's going to help that swallowing or that deglutination process start to occur. This is an involuntary action. All right. The swallowing center in that medulla will coordinate whatever other actions are needed in order to move the food or the fluid into the stomach. And it should do this without the food going into the lungs, which is what we call aspiration, because we don't want food going into the lungs. Only air should be going in there, right? Your cranial nerves will assist with this. 5, 9, 10, and 12. Now, if someone has a problem with the muscles in that area, like Lou Gehrig's disease, or they had a stroke, or anything that affects that swallowing process, this is where we have to worry about aspiration. All right, this is just showing you the teeth, the palate, the ducts. You can see the little opening of the ducts there if you look underneath the tongue there. Next is your esophagus. Now, esophagus is made up of skeletal muscle, and it has smooth muscle fiber. So again, we're going to see some action there. The entire tube is lined with mucous membrane, and it's closed except when we swallow. Cranial nerves 5, 9, 10, and 12 help produce that swallowing mechanism through a series of actions. So the soft palate's pulled up, the vocal cords become approximated, the epiglottis will cover the larynx, okay, and that's going to keep the food from going into the lung. Your breathing will stop for a second, and then the bolus is picked up by the pharynx, and it moves down into the esophagus. Peristalsis starts there. That pushes the food down. And then at the distal part of the esophagus, the food goes through the hiatus. This is at the opening of the diaphragm, and it enters into the stomach and the abdominal cavity. Now, right there, you have something called the lower esophageal sphincter. And that is supposed to relax before the bolus gets there so that it can drop into the stomach. And then it should close again. In some people, they have a problem with the lower esophageal sphincter, and that would lead to something called GERD or regurgitation. The food is going to come back up into the esophagus. So if there's a problem with that lower esophageal sphincter. Now, I did tell you that the lower esophageal sphincter, that's what I like to call it, LES. Okay, but some books will call it gastroesophageal or cardiac sphincter. They're all the same sphincter. The pressure in the lower esophageal sphincter will prevent that reflux or that gastric content from flowing back into the esophagus. So that's important for you to know, because if they ask you about GERD, all right, that's going to be the problem with GERD, is that lower esophageal sphincter. All right, think of the stomach as this sac, and it's a sac that can expand, and it can hold food and fluid, about 1 to 1.5 liters of fluid and food. And as it empties, okay, it'll go into folds. As it expands, those folds will expand outward. The stomach has 3 smooth muscle layers, and those muscle layers are going to help the action of what's going on in the stomach. You also have mucosa and submucosa, and those prevent anything from penetrating into the stomach wall. If something penetrates in there, then you're going to have damage there, like in a ulcer. Okay, so the mucosa prevents the acid and the pepsin from going into the wall. The mucosa prevents the acid and the pepsin from going into the wall. All right, so now the body is going to make this chyme. And chyme is like this creamy material, okay? And it comes from churning and mixing the food. The body's adding some secretions from the gastric glands. And that's what makes the chyme creamy, milky looking. And that is also going to initiate the process for protein to be digested. So gastric glands in the fundus of the stomach have parietal cells. This is very important. You got to know this. Okay. The parietal cells are going to secrete hydrochloric acid. You also have chief cells there. Chief cells secrete pepsinogen. And this is going to be converted into pepsin by the hydrochloric acid. So parietal cells are going to secrete the hydrochloric acid. The chief cells will secrete the pepsinogen. The hydrochloric acid will then convert the pepsinogen into pepsin. You also need intrinsic factor. And this is required in order for your body to absorb B12. Remember, B12 is very important for your nerves, for the myelin sheath on those nerves. Okay, so the intrinsic factor is going to help us absorb the vitamin B12 in the ileum. And remember, the ileum is responsible for what?
Absorption.
Absorption. Okay, so intrinsic factor also produced by the parietal cells. So now you know the parietal cells produce hydrochloric acid and intrinsic factor. Okay, chief cells secrete pepsinogen, which is converted to pepsin by that hydrochloric acid. The intrinsic factor is going to help you absorb B12, and that would help us prevent what?
Vitamin B12.
Anemia.
What type of anemia?
Pernicious anemia.
Pernicious. Good. Pernicious anemia. Okay. So gastric secretions, these are part of your defensive system. They're very acidic. They can destroy any bacteria that's trying to get into the stomach. Remember that we have resident flora in the mouth. That can come in from food, also from utensils. So the body is trying to protect you here with these gastric secretions. Glands that are located in the cardiac and pyloric areas will secrete protective mucus. And then you have enteroendocrine cells there, and these can secrete a variety of chemicals. The most important one is gastrin. Okay. And gastrin is released whenever food enters the stomach and stimulates the parietal cells and the chief cells. Gastrin is released whenever food enters the stomach and stimulates the parietal and the chief cells. All right. So some things that can really stimulate this are things like smoking, coffee, and that's going to promote gastric emptying. Okay. We'll talk about that in a little bit. Depending on the type of food that you eat, the gastric emptying is then going to occur slowly. And again, it's going to be small amounts of that kind, okay, going through that pyloric sphincter into the duodenum. So it's about 1 to 3 mLs. There'll be secretions also produced there from the liver and from the pancreas. Here, the pancreas is working as an exocrine gland, okay, and it's adding chyme in the duodenum. Remember, I said it happens in the duodenum because those enzymes would otherwise damage other parts of the body. So the enzymes that are being released to break down are also being released from the pancreas into that duodenum. You also have really small lipid molecules there that can pass through the stomach when it's empty, depending on what you've ingested. So an example of this would be alcohol. Alcohol is a small lipid soluble molecule. So when you drink it, it can diffuse easily into the blood. Now, why is that important? Because if you drink a lot of it, it can really increase your blood alcohol level. So you don't eat, you have 2 or 3 shots and you get pulled over, what's going to happen?
You're going to jail.
For sure. You're going to get a DUI. Okay. The other reason why this is important, if you think about it, is college kids. Okay. Because college kids, they like to go to those frat parties and drink large amounts of alcohol. And of course, they're poor, so they have to choose between the alcohol and food. So a lot of them don't eat. They'll go to these frat parties, and of course, it gets a little excited. And then what are we doing? Shot, shot, shot. So they start drinking absorbent amounts of alcohol, and then they end up with blood alcohol poisoning, and they can die. So where else does alcohol easily cross?
The
The blood-brain
blood-brain barrier.
barrier.
The blood-brain barrier. So you can see that this could do some pretty good amount of damage. So this is why your parents tell you if you're going to go out and drink, do what?
Eat.
Eat before, during, and after. All right, because that food in the stomach will delay the absorption. I think we skipped a page there. Let me go back. All right, so the hepatic portal system, this is where the largest vein in the abdominal cavity is. Okay, this is part of the hepatic portal system, the hepatic portal vein. It carries blood from intestines, gallbladder, pancreas, and spleen, and takes it to the liver where it can be filtrated and processed. This hepatic portal system is going to help clean the blood of bacteria and toxins that are picked up while it's being sent through the intestines. The nutrients are broken down into molecules that are easily able to be absorbed along with electrolytes and water and put back into the blood and then transported to the liver through the hepatic portal system. You have special liver cells there known as hepatocytes, and these can help drain blood back into circulation through the hepatic veins, through the inferior vena cava. You also have little sinusoids there that are filled with blood, and these two sources will pass between the plates of those hepatocytes. So it allows the blood to kind of flow back and forth between those liver cells, be clean, and then put back into general circulation. Now that blood that is entering the sinusites is carrying oxygen, okay, and the oxygen is going to the liver cells. It also has venous blood from the portal vein, which is bringing nutrients that are absorbed from the stomach and the intestines, as well as from the pancreas and the spleen. The arterial and the venous blood there will sometimes mix and flow slowly through those sinusoids to allow those liver cells or those hepatocytes to do their job. The sinusoids are lined with epithelial cells and Kupffer cells. Now, Kupffer cells are special cells that we find in the liver, and these are going to help to remove foreign material and bacteria through phagocytosis, all right, and then it'll clean that blood, all right, getting rid of that bacteria and putting it back into general circulation. Also, as the blood flows through those sinusoids, it helps exchange certain things that are going to help with liver function. So nutrients that are going to be taken up by those liver cells or those hepatocytes are going to be minerals like iron and copper, vitamins like A, B6, B12, D, K, and folic acid. The blood components like iron and amino acids can also be monitored there. And if they've been depleted for some reason, the body can replace them. Blood glucose levels are also maintained here in the liver. The insulin, okay, when the insulin is released, the liver will respond to high levels of the blood glucose by glycogenesis, and it will convert glucose to glycogen and stores it in the liver. So remember, insulin helps that glucose to get into the cell. Without that, the liver can't do this process. So when someone has type 1 diabetes, we got to make sure that they're getting their insulin. The hepatocytes will break down the liver glycogen to glucose whenever the blood glucose levels drop, and then glucagon will be secreted. Okay, now you know about glucagon because you have it in your units. And if someone has a really low blood sugar, you might have an order to give this. But in the normal person, okay, as the liver responds to the high levels of the blood glucose, it's going to perform this glycogenesis. It's going to convert the glucose to the glycogen, and it's going to store it. So when your blood sugar drops, it can correct it. And so it will do that, okay, when the blood sugar drops by secreting that glucagon that has now been stored in the liver. Gluconeogenesis, or formation of glucose, can take place whenever blood glucose levels drop or under the influence of hormones like cortisol or epinephrine. Synthesis and control of blood levels or other materials such as plasma proteins, clotting factors, or lipoproteins are all regulated by that liver. Cholesterol synthesis also occurs in the liver. So this is how your body makes those steroid hormones, your cortisol, your sex hormones, or your bile salts. And then aldosterone and estrogen are inactivated in the liver, and that helps to excrete it from the body when we need to. So when would we need to excrete aldosterone? First, think about what aldosterone does. What does it do?
It helps to control your body fluid balance.
It absorbs sodium and water.
Okay, that's a much better answer. That's a much better answer. It helps us reabsorb sodium and water. When would we not want to reabsorb sodium and water?
When you're dehydrated?
When you hyperventilating.
Think about it. When would we not want to reabsorb sodium and water? Why would we not want to do it in dehydration?
During like fluid overload.
let's just go back for a second because I heard someone say dehydration. Those of you saying fluid overload, that's correct. And there's a couple other conditions. But dehydration, we're lacking fluid. So we are going to want to reabsorb.
When you have too much
Okay.
salt and too much sodium.
Okay. So usually this is in salt-induced hypertension is what we call it, right? In those cases, the body would release ANP. Remember we talked about atrial natriuretic peptide? Remember I called that the snitch bitch? Because the body's going to release it. It's going to go to the kidneys and it's going to stop us from reabsorbing the sodium and water. So it's going to inhibit the aldosterone because we don't want our blood pressure to keep going up, right? And we don't want to have too much fluid in the body. So whenever we have too much fluid, okay, or too much salt and water, we definitely want to reduce aldosterone. So when the body recognizes that that's happening, the liver is going to try to help get rid of some of it. Okay. That's where it's excreted from. But other processes in the body have to happen for that to be inhibited. One of those processes is that AMP being released. All right. Ammonia, this is made from nitrogen waste. Okay. And this occurs whenever protein is metabolized in the intestines or the liver. Okay. So ammonia has to be removed from the body. So you eat the protein item, the body's going to break it down and it's going to produce ammonia, which is nitrogen. Okay. And so it has to be removed from the blood. Drugs and alcohol are detoxified in the liver. Okay. Damaged or old erythrocytes can be removed from the blood here when body's recycling iron and protein from the hemoglobin. So remember last week we were talking about blood and we were talking about how the heme breaks down once it's been used, right? And it splits and the body will recycle the heme part and the globin. Okay. The liver acts as just like a spleen. It acts as a blood reservoir. It can also release a large amount of blood into circulation if the blood was depleted for some reason. Those liver cells or those hepatocytes produce bile, and bile is absolutely vital for digestion. It also helps remove bilirubin and excess cholesterol from your body. Bile salts formed from cholesterol are essential for emulsification. So remember, we talked about emulsification. That's breaking down those fats and those fat-soluble vitamins, A, D, E, and K, so that they can be absorbed from the intestines. All right, the pancreas, this is going to be just behind the stomach. It secretes digestive enzymes, electrolytes, and water. And it does it through these little ducts that drain into the main pancreatic duct. That is going to carry the secretions from the pancreas into the common bile duct and into where? Where did I say those pancreatic enzymes are going?
The bottom.
The duodenum, good. Okay. And that's where they're going to work at. So major proteolytic enzymes in those pancreatic secretions are trypsin, chymotrypsin, carboxypeptidase, and ribonuclease. That pancreatic amylase is going to help digest carbohydrates, and lipase is going to help digest fats. These enzymes are secreted in an inactive form. They are not activated until they reach the duodenum. And this is because we don't want damage to other areas of the body. Pancreatic cells then will produce a trypsin inhibitor. And that helps reduce the risk of enzyme activation in the pancreas itself. Pancreatic secretions also have bicarb. And bicarb is helpful in neutralizing any hydrochloric acid that might have entered that duodenum. Now, again, the small intestines is the duodenum, the jejunum, and the ileum. So the contents is going to enter there slowly, and enzymes are then added in that duodenum, okay, to sort of decrease the amount of acid there and to start that process of digestion, breaking down so we can absorb the nutrients. The ileum is where most nutrients are absorbed. There are villi and microvilli there. They look like little finger-like projections, and they can increase the absorption surface area in the small intestines. So with babies with dumping syndrome, usually they have damage in their intestines, and part of the intestines isn't working. So we call it short gut because some of it's been removed. So what they're doing now is they're trying to transplant more villi and microvilli in these babies so that they have a bigger area for absorption because they have an absorption issue and they usually end up with malabsorption problems. In those villi are little networks. There's also a lacteal there, and that is used for lymphatic fluids. Okay, it helps to absorb lipids. At the base of the villi, there are little what we call intestinal crypts. These are really deep pockets, and epithelial cells will rise up from there. But also in the crypts, okay, they can activate some of those pancreatic proenzymes and hormones like cholecystokinin or CCK. There are also enzymes in there that help with intestinal, other intestinal duties or functions. Okay, the peptidases, the nucleosidases, your lipase, your sucrase, your maltase, and your lactase. You also have goblet cells there, and they're going to secrete large amounts of mucus into the intestines, and that's going to help to protect and buffer the area from that acidic kind. In the ileum, there are also something called Peyer's patches. And these Peyer's patches are large amounts of lymph tissue. Now, remember, lymph tissue helps with your immune response. Okay, so this lymph tissue is going to protect the intestines, okay, by mounting this immune response against any of that resident bacteria that tries to spread there or create any sort of problem. So Peyer's patches are lymph tissue that's trying to prevent the spread of resident bacteria into the small intestine. All right, so we learned about some of this stuff just a few minutes ago. Salivary amylase, that is in the mouth. That's going to start the digestion of those carbohydrates. Pepsin is secreted by the chief cells. First, we have pepsinogen, right? And then what will convert that pepsinogen into pepsin?
Hydrochloric acid.
Hydrochloric acid. Okay, and then we have the parietal cells, and they are producing what?
Pepsin. Intrinsic factor. Intrinsic factor.
Intrinsic factor and
Hydrochloric acid.
Hydrochloric acid.
okay. We need that intrinsic factor for what?
To help with
Absorption,
absorption of
absorption.
B12.
Vitamin B.
Okay, to help with absorption of that B12. We know that the pancreas is releasing certain chemicals, enzymes. Where are those enzymes going to go to do the process?
Duodenum.
Yes. Okay, and it's going to be trypsin, chymotrypsin, carboxypeptidase. Okay, those are all going to help to break things down, those proteins. All right, and then the pancreas is going to release what to prevent itself from being eaten up or destroyed? Trypsin inhibitor. Okay, it's going to produce a trypsin inhibitor to stop itself from being damaged. All right, now next is the large intestine. So the ileocecal valve will mark the entry area from the ileum into the large intestine. And then as we go down the intestines, we have the cecum, which is the ascending colon. That will become the transverse colon. That will pass down the left side as the descending colon, and that will terminate into the sigmoid colon, the rectum, and the anus. We have a large amount of water and electrolytes being absorbed here. This is going to help you maintain your fluid and acid balance. Digestion and absorption of nutrients stop in the colon. Residential bacteria will continue to help us break down certain materials. It will convert bilirubin into urobilinogen, and that will convert the stool or the feces into this brown color. Now, when you don't have bilirubin and that process isn't working, you have a problem with your pancreas or your gallbladder, your stool usually isn't going to be brown. It's going to be white or clay colored. Now, the bacteria here are beneficial to us. They help to synthesize vitamin K, which we need in order for blood clotting to occur. All right, vitamin K is used to produce prothrombin and fibrinogen, and so it's used in the liver. There's also large pouches in the colon. These allow the colon to expand as more solid material collects there. The feces is primarily going to be fiber and other things that are not digestible. So like sloughed mucosal cells, bacteria. Any increase in bulk or fiber increases the ability of the body to push it out. So it increases that intestinal motility and the rate of passage. So this can result in a large fecal mass and more frequent defecation or bowel movements. So as the rectal wall is stimulated, it's going to stimulate the defecation reflex. And what stimulates the rectal wall is distension. Then there are nerve impulses there that are transmitted to the spinal cord. You have the sacral parasympathetic nerves here that transmit motor impulses to stimulate peristalsis, relax the internal anal sphincter. Pelvic muscles contract. You have voluntary relaxation of the anal sphincter, and that will allow defecation to occur. Elimination of feces is assisted with an increase in intra-abdominal pressure through voluntary contraction of the abdominal muscles and the diaphragm. If this process is under voluntary control, the external anal sphincter will stay closed. The defecation reflex will subside. And then as the fecal mass increases again later, the reflex would be stimulated all over again. The small intestines, okay, this is going to help us with digestion and absorption. All right, so you have amylase that's being released from the pancreas to break down those carbohydrates. And lipase is going to help break down the fats. You have trypsin and chymotrypsin from the pancreas. It's going to help to break down and digest those proteins. And then once absorbed, the nutrients will go into the body through either diffusion. So we just talked about diffusion with the alcohol. That doesn't need much. It can just simply go in there. Some of these things have to be carried into the body through active transport. So we're going to need some kind of energy to do that with. All right, parasympathetic nervous system. Remember, we call this rest and digest. Okay? So sympathetic nervous system is fight or flight. This is the opposite. Rest and digest, parasympathetic. All right, and it works primarily through the vagus nerve or cranial nerve 10. So with rest and digest now, we're going to have, because we're digesting, we're going to have an increase in motility. We're also going to have an increase in secretions like saliva because that starts the process, right? And those other enzymes that we need in order to break things down. During the initial cephalic phase, before you eat, smells, thoughts, and the sight of food can start the parasympathetic nervous system stimulation. And you kind of know this because if you cooked like a long Thanksgiving dinner, all right, when the smells start, it almost fills you up. You haven't even eaten anything, but you're getting the smells and it's stimulating this parasympathetic nervous system. Okay, so you'll have a little bit of saliva. And even though you only eat a little bit of food, you feel full. Now, certain emotions like fear, anger will stimulate the sympathetic nervous system. So that's going to inhibit your GI activity. All right, which is good because you don't want to poop when you're trying to run from the bear. You don't want to crap your pants. So we like it when it's inhibited for that reason. All right, you do have to know the differences here. Parasympathetic nervous system, mainly through that vagus nerve or cranial nerve 10, will have an increase in gastric motility and increase in secretions like salivary amylase, your pancreatic enzymes. These are going to all help you start to digest. And sympathetic, it's going to constrict. Okay? It's going to reduce the regeneration of those epithelial cells. It's going to reduce that salivary amylase. It's going to reduce those enzymes. And it's going to slow down that GI activity. All right, gastrin, we talked about this, okay? Gastrin is going to be released anytime food enters the stomach. Things that will stimulate it particularly are protein, caffeine, and we'll see an increase in gastric secretion and gastric emptying. Cholecystokinin, this is the opposite. It inhibits gastric secretions and motility. Secretin, this is going to stimulate bile and pancreatic secretions, especially those with high bicarb content. All right, and this is going to happen anytime we have too much acid in the duodenum. So it'll stimulate the pancreas to release the secretin. Remember, it's high bicarb, so it's going to help neutralize the acid in the duodenum. Cholecystokinin, it's going to be stimulated whenever there's protein and fats entering the duodenum. So it's going to stop the gastric secretion and the motility. It'll stimulate the pancreatic enzymes because pancreatic enzymes have to go where?
To the duodenum.
Okay. And in there, they're going to start to break down the fats, the proteins, okay? Trypsin, chymotrypsin. And then parasympathetic nervous system, that's the vagus nerve, okay? The stimulus is the taste or the smell of the food, and that's going to increase your secretions and your peristalsis. Sympathetic nervous system, any kind of stress is going to decrease secretions, decrease peristalsis. All right, so in the mouth, we have some cranial nerves. These help maintain the flow of saliva in the mouth. All right, so cranial nerve 8 and cranial nerve 9, the facial and glossopharyngeal nerves, they are called. These are part of the parasympathetic nervous system to help maintain that continuous flow of saliva, to keep the mouth moist, to cleanse it, and to help with speech. If you have a dry mouth, then it can cause you to be thirsty, okay? And that's good because that thirst tells us that we need to do what?
Hydrate.
Drink, hydrate, right? So we don't get dehydrated. So remember that any sight, thought, or presence of food in the mouth will stimulate those salivary secretions. All right, once the food reaches the stomach, distension or stretching of the stomach and an increase in the pH from the food itself activates the parasympathetic nervous system. That is going to increase peristalsis and gastric secretions. The parasympathetic nervous system stimulation will also increase bile and pancreatic secretions. Depending on what type of food we eat, the stomach will empty in about 2 to 6 hours. Fluids obviously go through it a lot faster and fats a lot slower. Food in the intestine will stimulate the intestinal activity, but inhibit gastric activity so that we don't overload the duodenum. Remember that we have to allow time for digestion and absorption. So only a little bit of amount of food can go in there at a time in order for that process to occur appropriately. Food goes into the small intestines at a pretty constant rate, and then a reflex will increase the peristalsis around the ileocecal valve after you eat to move the ileal contents into the cecum and the colon. There's also a gastrocolic reflex that can stimulate a mass movement of the contents from the colon into the rectum whenever food enters the stomach. Hormones play a pretty major role in digestion and absorption. So you have to know these. All right, gastrin secreted by the mucosal cells whenever the stomach is distended or when certain substances like protein, alcohol, or caffeine enter the stomach. Gastrin enters the blood and circulates, and then it will stimulate the gastric cells to increase those secretions, gastric motility. It also helps relax the pyloric and ileocecal sphincters so that food can move, okay, from the stomach or from the ileum into the colon. Okay, so that's going to help the food move either from the stomach into the duodenum where it can be processed, or move the stuff that's already been processed from the ileum into the colon. Histamine from H2 receptors is released from local mast cells, and this is going to increase secretion of hydrochloric acid. As the chyme enters the duodenum, those mucosa cells will release secretin and cholecystokinin. Secretin will decrease the gastric secretions and increase bicarb. And this is going to help with that highly acidic chyme. Cholecystokinin will inhibit gastric emptying, stimulate those pancreatic secretions with an increase in those digestive enzymes to stimulate contraction of the gallbladder and increase the bile flow into the duodenum. So remember, we need the bile and those enzymes that are being secreted by the pancreas in order to break everything down. We need a combination of both because we're breaking down fats, we're breaking down carbs, okay? So all the things that the body is producing here are essential for this process to occur appropriately. So the nutrients are broken down and absorbed along with the electrolytes and water into the blood. Then they're transported in the liver through that hepatic portal system that we talked about. Complex carbs are like starches are digested first in the mouth and then the intestines. They need active transport. Okay, so we need healthy cells with a good blood supply there. Proteins are first going to be split into peptides or short chains of amino acids. Now, you should have learned about those amino acids in nutrition and how your body needs certain ones. And in order to make them, you got to eat certain foods. This is why if someone's on a vegan diet or some kind of diet where they're not eating the foods that can make these amino acids, we have to educate them on what they could eat in order to make these. In the stomach and the intestines, the food is then broken down further into amino acids by peptidases, and then absorbed in the small intestines. Lipids are fats, primarily your triglycerides have to be emulsified first. And this is done by the bile and the bile salts in the small intestine. And then the enzymes will act on fats and they will break the fats down to make monoglycerides or free fatty acids. The lipid-soluble molecules are able to diffuse across the cell. Lymphatic capillaries in the intestinal villi, remember those little finger-like projections, will help absorb and transport the lipids. And it transports them as something called chylomicrons. And this is the lipoprotein that carries the triglycerides into the blood during the digestive process of breaking down those fats. Biosalts that are made from cholesterol help to emulsify the fats and the fat-soluble vitamins like A, D, E, and K, so the intestines are able to absorb them. Water-soluble vitamins like B and C and minerals like iron, copper, and zinc are able to diffuse into the blood. Electrolytes like sodium, potassium, chloride, bicarb can be absorbed through active transport or some of them by diffusion, depending on which ones we're talking about. And then drugs are going to be absorbed into the intestines. Okay, some of them are small acidic molecules like aspirin. Those can be absorbed in the stomach. Now, remember, I brought this to your attention because as a nurse, you're given a lot of medications through tubes. Where are those tubes going? What kind of drugs are you given? Can those drugs be broken down there? Are there questions you should be asking the doctor? And I bring this to your attention because if you look at the back of the directions on those boxes and those manufacturers' supplied instructions, you'll see none, and I mean none, that tell you how to give it through a tube. All right, water is absorbed by osmosis about 7,000 mLs into the digestive tract each day, about 2,300 in food and fluids. Only about 50 to 200 leave the body in feces. In feces, severe vomiting or diarrhea can really interrupt this process and affect the fluid and electrolyte imbalance or balance in the body. All right, next we're going to talk about manifestations of the digestive system. So anorexia, nausea, vomiting, and bulimia. And these are different, but all of them can be signs of a digestive system issue, or it could be a problem somewhere else in the body. For example, if someone had uremia, this is a systemic infection, okay? And it's usually caused by kidney failure. So they could have emotional responses because they're afraid of dying. They can have motion sickness. They can have pressure in the brain or overindulgence of food. So all these things, the kidney failure, the emotional responses, the motion sickness, pressure in the brain, all these could lead to things like anorexia, nausea, vomiting. Nausea and vomiting are usually an indicator of some GI issue. And we also look at the characteristics and the pattern of the vomiting when we try to diagnose. Vomiting is also a body defense because if we have something noxious in our body, it'll help remove it. Anorexia and vomiting can contribute to complications like dehydration, acidosis, and malnutrition. A lot of times, if someone has nausea and vomiting before that, they're going to have this feeling of anorexia or not wanting to eat. Nausea is generally an unpleasant, subjective feeling. It can be stimulated by distension of the stomach, irritation, or inflammation in that digestive tract. It's also stimulated by certain smells, images, pain, or some chemical toxins. Drugs as well. That vomiting center is going to be located in the medulla, and it's coordinating the vomiting and activity involved. It helps close the glottis to protect the airway, and it helps stop respirations when we're vomiting so that we don't aspirate the vomitus into the lungs, because that can lead to inflammation and obstruction of the airway. Any vomiting or emesis is considered forceful expulsion of the chyme from the stomach. Sometimes it will also have things like bile in it from the intestines. Sometimes they can vomit feces. Bulimia is an eating disorder. The client will binge and overeat, and then after that, they will induce vomiting, take laxatives, or try to starve themselves to avoid weight gain. This is considered a behavioral disorder, but it usually will have adverse effects on the digestive process and some of its structures. So typically what will we see? We'll see damage to the knuckles. Okay, they'll have scrapes on their knuckles from putting their fingers down their throat to induce vomiting. Once they induce the vomiting, then they're going to develop things like erosion or tears of the esophagus because it's acidic, constipation, diarrhea, electrolyte imbalances, damage to the teeth, damage to the esophagus itself, damage to the oral mucosa. So what happens is we have irritation or distension of the digestive tract, some sort of stimulus that causes the brain to look at it as an unpleasant sight or smell or ischemia. We can have pain or stress or motion sickness. All these things, increased intracranial pressure, they can all stimulate the vomiting center to be activated here. With increased cranial pressure, this is projectile vomiting, like in The Exorcist. And we only really see it in two conditions. Increased cranial pressure is one, with no introduction of food. And then pyloric stenosis, where we have an introduction of food. So sometimes we'll see that in babies. Older adults can develop it as well. But the babies are born with this pyloric stenosis. And so about 3 weeks in, they'll start this projectile vomiting whenever they're fed. Again, you have retching. A lot of times people will gag before they vomit. So that's what retching is. Okay. The vomiting reflex will include the following involuntary activities. So you take a deep breath, the glottis will close, it'll raise the soft palate, your respiration will stop so that you don't aspirate. This will relax the lower esophageal sphincter. The abdominal muscles will contract and squeeze the stomach against the diaphragm and force the gastric contents up and out of the mouth. Expulsion of the contents from the stomach by reverse peristaltic waves will occur. All right, so these waves can come from the duodenum and the antrum of the stomach. The chyme, whenever you retch, the chyme will ascend into the esophagus and then drop back into the stomach. So sometimes when people are gagging, that's what's happening. The chyme is going into the esophagus, falling back into the stomach, and after they retch or gag several times, then they actually vomit. This can be very exhausting and painful because there are strong muscle contractions with each episode. There's also a risk of aspiration whenever the person is supine or unconscious, or they've taken something that's depressing the central nervous system, or that vomiting reflex. So things like alcohol, narcotics. We look at the blood for its color and its presence. So blood in the vomitus, if it's brown or if it's granular looking or coffee ground looking, then we consider that partial digestion of protein. And usually that's from some sort of GI bleed. The blood is in the GI area and it's irritating that area. Okay. Yellow or green stain vomit is usually from bile, and that's usually coming from the duodenum. If it's a deep brown color, then this can be from the lower intestines. Remember, I said people can vomit fecal matter. Usually we'll see this when someone has a small bowel obstruction. And then recurrent vomiting of undigested food from previous meals indicates a problem with gastric emptying. So that could be something like some sort of pyloric obstruction. Remember, if the pyloric sphincter is obstructed, the food can't move into the duodenum. Diarrhea, this is considered excessive frequency of stools. They could be loose or watery. It could be acute or chronic. It's usually accompanied by nausea and vomiting if there's infection or inflammation of the digestive tract. In other cases, that might happen alone. Sometimes we'll have cramping pain with it. Severe or prolonged diarrhea can cause dehydration, electrolyte imbalances, acidosis, and malnutrition. If we see blood, mucus, or pus in the stool, that can help us to either monitor or diagnose. So we can have large volume diarrhea. This can be secretory or osmotic. A lot of times we call diarrheal diseases enteral colitis. Large volume diarrhea causes a watery stool, and it's because of some kind of increased secretions in the intestines. It can be from an infection, a very short transit time, meaning the food or the fluids are moving really quickly, like in short gut or dumping syndrome, and that limits the reabsorption process. Electrolytes won't be absorbed properly. And it also can't absorb the proper amount of water. So this can result in a greater amount of watery stool. A common cause of osmotic diarrhea is lactose intolerance, because the lactose is not able to be digested or absorbed in the intestines, and that increases the amount of osmotic pressure. If the body is not able to properly absorb carbohydrates, this can cause water to be drawn or pulled into the intestines. This can cause osmotic diarrhea. This can happen if someone has an intolerance to carbohydrates, like lactose, maltose, sucrase, or fructose. It can also happen in certain disorders like celiacs. There are medications that can also cause osmotic diarrhea, certain laxatives, okay? And sometimes we want that effect, so that's why we gave it. Small volume diarrhea often occurs in inflammatory bowel disease, and this stool can contain blood, mucus, or pus. The diarrhea can be accompanied by abdominal cramps or what we call urgency. Stenorrhea, we usually see this with like cystic fibrosis, or we could see it if someone has a pancreatic issue. So we'll have frequent, bulky, greasy stools, and they smell funky. These are characteristic of malabsorption syndromes. So celiac disease, cystic fibrosis, the food intake is not digested or absorbed here. That is usually the first component that's affected. And the fat will interfere with digestion of other nutrients. The abdomen will be distended here because bulk remains in the intestines. The malnutrition would be apparent in other tissues unless the person has edema because of hypoproteinemia. Now, hypoproteinemia is what? Hypo is what?
Low.
Excessive protein in the blood.
Okay, good. Break the word down, guys. You can do this. Okay, low protein in the blood. Now, what is the main protein that we're looking at?
Albumin.
Okay, and remember I said albumin is a water magnet. So If they have edema, a lot of times that edema is going to be seen because they don't have enough albumin. And here we're talking about it again. That's exactly what they're saying here. Blood can also occur in normal stool with diarrhea or constipation, especially with inflammatory conditions. Frank red blood is going to be blood on the surface of the stool. And it usually comes because of a lesion in the rectum or the anus itself. And it's blood that has not been digested. Occult blood is small hidden amounts of blood. You can't see them with your eyeballs. So what you can do is the Guillac test. Okay, and that can pick up if there's blood in the stool. The stool will usually be black and tarry looking, all right, or that melena, all right, which is that dark colored tarry stool, and it usually comes from bleeding. And here we have intestinal bacteria that have acted on the hemoglobin, and that's causing it to have this black or this dark color. But you can also see dark stools in people that take what?
Iron.
Pills,
Iron.
furosulfate.
So aspirin, I heard iron. What's the other one? Pepto-Bismol.
Yeah.
That's another one. Okay. All right, gas we get from swallowing air, from like drinking too much from a straw. You might also get this or see this in someone who had some sort of surgery because, they put gas in there to extend or distend, I should say, the abdominal area. So when they're in there doing some sort of laparoscopic procedure, they can see and move without doing any sort of damage. The gas can be from air, digestive, or bacterial action on food. Certain foods will alter the motility and promote gas production. So like your cabbage, your beans. Excessive gas is sometimes called belching or eructation, okay? A lot of times these people that are belching will have abdominal distension and discomfort, and they can either relieve it through belching or eructation or sometimes from flatus or passing gas. And then we have borborygmus. Okay, this is rumbling or gurgling sounds from the gas in the intestines. So again, you might hear this in someone that is post-op and they had a lot of gas put into the stomach or into that area to distend it. Constipation here, we have less frequent stools. They're going to be harder. It can be acute or chronic. Sometimes it will alternate back and forth between constipation and diarrhea. Sometimes emptying of the bowel with diarrhea can lead to decreased peristalsis and lead to an increased time available for resorption of fluid. So that can cause the feces to be hard or dry. And that dry feces or that hard feces irritates the intestinal mucosa. That can cause inflammation and increase in secretions. Once the hard feces is expelled, diarrhea may occur afterwards. Chronic constipation can cause development of things like hemorrhoids or diverticulitis. Severe constipation can lead to fecal impactions and intestinal obstruction. We'll usually see pain and abdominal distension with that. And then watery diarrhea can also mask a fecal impaction because the fluid will seep around the lodged compaction in the rectum. Some things that cause constipation. Weakness of the smooth muscle. Remember, smooth muscle causes activity or motility in this case. Inadequate dietary fiber. Not enough fluid intake. Not using the defecation reflex. So in other words, like people will sometimes not poop around other people. So if you constantly do that where you're so afraid of pooping around other people that you're not using the reflex, you can lose it. Muscle weakness and inactivity. So this could be for someone that's bedridden or someone that's losing muscle strength because of some other issue. Neurological disorders like multiple sclerosis or spinal cord injuries, use of things like opioids or other central nervous system depressants and anticholinergics. They can slow peristalsis. Some antacids, iron medications, and bulk laxatives can also lead to constipation, as well as obstruction by tumors or strictures because they can delay the passage and cause excessive reabsorption of fluid. Dehydration and hypovolemia are common problems of the digestive tract system. When we have vomiting and diarrhea, along with a lack of appropriate fluid intake, fluid shifts can occur from the blood into the digestive tract. If prolonged intracellular fluid is decreased, we can develop hypovolemia with impaired circulation and cellular dehydration. The cellular dehydration can cause decreased function in the tissues and the organs. Babies and elderly people are going to be at high risk for this because of the amount of water to body ratio. Remember, for babies, I think your book says 70%. Most nursing books will tell you 90% water. All right. And then the older adult is about 45%. So if you're middle-aged or, at that young adult stage, then you'll have about 55%. In addition to the water body ratio, their kidneys are not able to compensate quickly for losses. I would know those two things. Sodium can be lost whenever we vomit or whenever we have diarrhea. Gastric secretions are also high in chloride, so we can lose hydrochloric acid, and this can cause us, if it's extreme, to develop metabolic alkalosis. We also lose hydrogen ions, and we can develop hypochloremia if the bicarb levels increase because of compensation in the body. Diarrhea can lead to significant losses of potassium alkylaceum, and this can cause metabolic acidosis. If vomiting is severe, there can be a change to metabolic acidosis. So remember, originally you'll get metabolic alkalosis, but if it continues, you can eventually develop metabolic acidosis. And then those duodenal secretions have large quantities of bicarb that are lost, and ketoacidosis develops because of a lack of glucose. The lactic acid starts to accumulate. The person doesn't have enough fluid here, so they're developing hypovolemia, and that contributes to the metabolic acidosis. And the body may not be able to compensate, okay, if the kidneys are not able to respond. Now, lactic acid is a byproduct of metabolism. As your cells convert glucose to lactic, the body uses it for energy in anaerobic glycolysis. The cells do this when they need immediate energy that the body can't supply with oxygen. But the problem is it can cause lactic acid to build up in the body. This also happens when someone's doing excessive exercise. This helps us if our muscles or tissues are deprived of oxygen. But again, the lactic acid can build up in the bloodstream. And if you produce too much, all right, then it can cause your pH levels to fall. And again, that's going to cause acidosis, which can lead to organ failure, death, depress the central nervous system. Visceral pain, these are pain fibers that are connected to the autonomic nervous system. with autonomic responses such as pallor, sweating, nausea, vomiting are going to occur with this type of pain. This type of pain comes from the organs in the digestive system. So we might have inflammation and ulceration in the upper digestive tract because of ulcerations in the mouth or possible heartburn. A dull aching pain in the right upper quadrant because of stretching of that liver capsule. Cramping or diffuse pain is typically related to inflammation, distension, or stretching of the intestines. And then colicky pain, you should know this. This is from recurrent smooth muscle. And it's usually in response to like a gallstone or something like that being stuck in the duct. And then somatic pain, which is coming right from your spinal nerves. This is characterized by steady, intense, well-localized abdominal pain, and usually it indicates involvement or inflammation of the parietal peritoneum. There's a lot of pain receptors there. This is the basis for rebound tenderness. I talked about that the other day. This is when you take your fingers and you press down between the iliac crest and the umbilicus. And when you release, they have what we call rebound tenderness. It's a strong pain they'll feel when you release it. And this is associated with acute appendicitis. And then referred pain, you guys are familiar with that. We'll see that sometimes in pancreatitis, where they have pain in the pancreas, but they'll feel it in the lower back or some other part of their body. Malnutrition is next. This can be limited to a specific nutrient, okay, or it can be general. So like you can have a B12 deficiency because you don't have that intrinsic factor from the gastric mucosa. Malabsorption, liver damage, and bleeding ulcers can cause iron deficiencies. General malnutrition can come from anorexia, vomiting, diarrhea, malfunction of the GI tract in general, or some of those inflammatory bowel disorders, okay? So the difference between Crohn's and ulcerative colitis, Crohn's is a problem with malnutrition and malabsorption. Ulcerative colitis is not. We're going to talk about those a little bit more in detail, but definitely in Crohn's, you're going to have an absorption issue, not in ulcerative colitis. But in ulcerative colitis, you'll have that bloody, mucousy diarrhea, not in Crohn's. In Crohn's, you have like soft brown stool. The only time you'll see bleeding in Crohn's is if there's an abscess or a fistula or something like that involved. Wasting syndrome, we see this in AIDS, and this can lead to what we call cachexia, where we have severe muscle wasting, malnutrition, dehydration, any interference with your bile or your pancreatic secretions can cause a problem here. So we see this in people with cystic fibrosis because the thick mucus they have blocks the pancreatic ducts. So if you have someone you take care of with cystic fibrosis, you probably give them pancreatic enzymes in their food so that they can break down the fats and absorb the nutrients. They have to have that with every meal because their body's not able to produce enough of these pancreatic secretions because the ducts are blocked, the bile ducts are blocked, pancreatic ducts are blocked. Bad diets can cause a problem, all right? So you need those essential amino acids. These are required, okay? And we find those in animal products. So a vegetarian diet has to be careful to make sure that they include foods that allows for them to develop those amino acids. In a child, growth and development can be delayed or impaired by malabsorption or malnutrition. Outcomes of malnutrition include things like chronic fatigue, reduced resistance to any sort of infection, delayed healing. All right, obesity. Remember when we talk about obesity, this can be less than body nutrients because even though their body is overweight, they're not getting the appropriate nutrients that they need to help their body. Okay, so obesity occurs when the energy value of the food consumed is greater than what the body needs. and the BMI is going to be greater than 30, this is obesity. The condition is going to be seen in people who do not include fresh fruits or vegetables in their diet. And major complications are things like high blood pressure, atherosclerosis, type 2 diabetes, obstructive sleep disorders, arthritis, and congestive heart failure. All right, upper GI orders. Now we're going to talk about some disorders of the GI, of the oral cavity: dysphagia, esophageal cancer, hiatal hernia, GERD, gastritis, peptic ulcer, gastric cancer, dumping syndrome, and pyloric stenosis. Before I move on to that, any questions about the stuff I went over? You guys know what hormones and enzymes you need to know. You know where they're produced from. Where do they work at? Those are the kind of things they would ask you about in regards to GI disorders. Okay. Now we're going to talk about some of the actual disorders themselves. The first one is cleft lip and palate. All right. These are going to be developmental abnormalities of the mouth and the face that usually occur during the second or third month of gestation. Appear to be multifactorial in origin, so a number of things that can cause them, including genetics, environmental factors. Cleft lip can be unilateral or bilateral, and the exact definition is we have failure of the maxillary process to fuse with nasal elevations or failure of the upper lip to fuse. The lips fuse between 4 to 8 weeks of fetal development. The tissues from each side join together in the face to make the lip and the mouth. If that doesn't happen, they're going to end up with a cleft lip. The gap forms between the two sides of the upper lip. The cleft palate is the hard and soft palate do not fuse between 7 and 12 weeks of gestation. This creates an opening between the oral and nasal cavity. The cleft palate is a split or opening in the roof of the mouth, and it can include the hard palate, which is the bony front portion of the roof, or the soft palate, which is the back part of the roof. That's a little softer. You can feel it if you slide your tongue right across the top of your mouth. The infant has feeding problems because there's insufficient force developed in the mouth for the baby to suck, and it puts them at a high risk for aspiration of fluid into the respiratory tract. They can also develop speech impediments. Surgical repair is necessary. In addition, plastic surgery may be needed for growth defects or to improve appearance. So that's just a picture of it. Aphthous ulcers or aphthous stomatitis or canker sores are common. Now, your grandma probably told you you've been telling lies. Okay, these are little white sores you get in your mouth. They have a punched out white appearance surrounded by a red border, and they're small, shallow, painful lesions that occur in the mucosa, the buccal mucosa, the floor of the mouth, the soft palate, the lateral borders of the tongue. The oral cavity itself has large, varied resident flora. Bacteria thrive in the crevices of the mouth where it's moist and warm. Streptococcus sanguinis is a bacterium that's abundant in the oral cavity and could be a cause of these sores or ulcers. They are part of the Viridian streptococci. These ulcers will heal spontaneously in a week or two. Candidiasis is yeast, okay? Candidiasis albicans. The oral cavity has a large and varied resident flora, including many types of bacteria, in addition to fungi, viruses, and protozoa. They can cause opportunistic infections, such as candidiasis, or secondary infection if there's open lesions in the mouth. Candidal infection can appear as a red, swollen, or irregular patch of white curd-like material. So it's going to look like milk or cottage cheese stuck to the side of the mouth. Oral candidiasis or thrush is a common fungal infection that happens in people that are on broad spectrum antibiotics, have had chemo for cancer, or a large amount of glucocorticoids prescribed. It also can happen to those clients that are diabetic or immunosuppressed. So like your AIDS patients. Again, you'll see that curd-like picture there. Okay, develops. And this can actually go all the way down your esophagus. And you'll know when it does because, you know, in these clients, a lot of times that will happen with your AIDS patients where it will go down into the esophagus or babies. So when you're giving that nystatin, instead of swishing and spitting, you're having them swallow it so that they can coat the whole area. All right, herpetic stomatitis. This can be associated with herpes labialis or cold sores and fever blisters. We call this the gift that keeps on giving. A herpes infection is usually caused by herpes simplex virus type 1, and we can get it from kissing or close contacts, typically in childhood. So a lot of times it comes from our parents, okay, or grandparents. And the initial infection is asymptomatic, but the virus is still dormant in the body in the sensory ganglion, often the trigeminal nerve ganglion. Now, the problem is, even if you don't have an active blister, you can still be contagious. Okay, because it can be in that saliva. It can be activated by stress, trauma, or another infection. So you have already the herpes, okay, and now you got a wedding or prom coming up, or you develop a cold, and so this blood blister, this fever blister, this cold sore develops on your mouth. The virus will move along the nerve of the skin or the mucosa around the mouth, and it'll cause a burning or stinging sensation at the site. And then after that happens, the blister develops, the virus reproduces, and causes necrosis of the host cell. The vesicle rupture will leave the shallow, painful ulcer, and it releases a clear fluid that contains organisms, and then it crusts over. The lesion will heal about 7 to 10 days after the virus migrates along that trigeminal nerve, and then it'll enter a latent state and go into that sensory ganglion. Recurrences are common. If people are immunosuppressed, they may have multiple lesions. HSV1, herpes simplex 1, is present in the saliva for time after the vesicle has healed, and that saliva is still contagious. The herpes simplex can spread to the eyes, causing conjunctivitis and keratitis, and it's usually happening because of contaminated fingers or some sort of droplets. All right, this is called herpetic whitlow, and this is what happens. This is a dental person. They stuck their finger in somebody's mouth, probably didn't have a glove on. All right, and the person had herpes, and they got this infection in the finger. Also, syphilis caused by Treponema pallidum. This is the most common route of transmission. It's direct contact during sexual activity. Syphilis can cause oral lesions, highly contagious in the first and second stages. The primary stage will be a canker sore, and it's usually this painless ulcer found on the tongue, the lips, or the palate, and it heals spontaneously without treatment in about 1 to 2 weeks. The second stage is manifested by red macules or papules on the palate or by mucus patches, multiple irregular, loose, white necrotic material on the mucosa, and it's highly infectious. The lesions heal spontaneously. The lesions may be missed, so we need immediate treatment here in order to control transmission. Dental caries, a lot of these are caused by Streptococcus mutans. So we have a bacteria normally found in the oral cavity, and we have an increased number of lactobacillus and other acid-producing resident flora. The bacteria start to act on sugars that have been ingested through food, okay? And it creates a large amount of lactic acid that will dissolve the minerals in the tooth enamel, causing erosion of the tooth surface and causing the cavity to form. If we don't treat it, the decay can continue beneath the surface of the tooth until the internal structures are infected, like the pulpits or where the roots are for that tooth. Caries is promoted by frequent intake of sugar and acids. So that's your cavity, okay? They're calling it caries. It's the same as a cavity. So any sugar, acids, carbonic acid, and soft drinks all cause this to develop, all right? And you'll have pits or fissures on the tooth surface. They also can develop xerostoma or dry mouth with plaque formation and periodontal disease, which increases the risk of caries. Fluoride can be given. This is an anti-caries treatment. It decreases the solubility of the minerals in the enamel and enhances the remineralization process. So a lot of townships will put the fluoride in the water. The problem is what about the water? If the township puts the fluoride in the water, but what's the problem? What do you think? Who drinks the water from the sink? How many of you?
Not a
Not
lot.
me.
Not me.
How about your kids? What kind of water do they drink?
Nope.
Bottle.
So if there's no, and the bottled water may not necessarily have fluoride, but what does it have? Sodium.
Oh. Yep, sodium and calcium chloride.
All right, so fluoride can help prevent against cavities or caries. Okay, your book likes to call it caries, cavities. It's the same thing. The fluoride can prevent against it. Okay, and it can help with the remineralization process of the teeth. But too much fluoride can cause hypocalcification and deficient calcification of the tooth enamel. So we don't want to take too much fluoride in. Periodontitis is infection and damage to the periodontal ligament and bone, and this can cause loosening and loss of the tooth. Periodontal disease is usually because of poor oral hygiene, but it can also be aggravated by certain diseases and medications. So if you notice people that like shoot a lot of drugs, their teeth are terrible. All right, so you can see right there one example of what's happening with the teeth. But also certain other drugs, you got to make sure you brush your teeth. Another thing that can cause the teeth to break down is giving babies bottle of milk to go to bed with. That can rot their teeth. So they should not have milk or formula when they go to bed. Gingivitis or inflammation of the gingiva causes the gingival area to become red, soft, and swollen and bleed easily. This can be from accumulated plaque. There are also microbes that secrete substances that are able to adhere to the tooth surface and to the plaque. Calculus or tartar is calcified plaque, which irritates the tissue. Poor oral hygiene will put us at risk for gingivitis. Also, toothbrush trauma. So too much or improper brushing, using abrasives to clean your teeth with. These can all cause extensive grooving on the tooth surface, increase plaque retention, damage the gingivae, and make your tooth more sensitive. And then gingival hyperplasia, we usually see this with things like Dilantin, your seizure patients that are taking Dilantin, some pregnant women, use of drugs like cyclosporine. Overgrowth called pregnancy tumor can be from hormone changes with pregnancy use or oral contraceptives. Again, you're going to see some nasty pictures here, okay? That necrotizing ulcerative periodontitis. We also call this trench mouth. And this is a common infection from anaerobic opportunistic bacteria in people that have low resistance. It can also your risk factors can also be increased by stress, smoking, certain diseases, or nutritional deficits. So all those things can lead to this necrotizing ulcerative periodontitis. Periodontal disease. Okay, this is going to develop whenever we have gram-negative anaerobic bacteria that enter the plaque. The bacteria secretes toxins and enzymes that destroy the tissue and the white blood cells. The plaque and the calculus. The plaque and the calculus are progressed on the tooth beneath the gingival margin, causing inflammation around the root. There's also destruction of the periodontal attachment. So again, these people can lose their tooth. And also the enlarging periodontal pocket that forms around the tooth promotes even more anaerobic bacteria and infection. Here, the mucosa is red and swollen. It bleeds easily. The teeth feel loose. Gingivitis and poor oral hygiene can contribute to this. Periodontitis can be aggravated by smoking, which promotes calculus formation, cancer, chemo, or diabetes, and also poor healing from things like HIV or AIDS infection. So again, this is just showing you the calculus on the teeth. All right, so I pretty much covered all that. We're going to keep on moving. This is severe periodontal disease. All right, so again, the teeth in place are going to start to deteriorate. The gum and the tissue are destroyed, and you're going to have chewing issues here, bad breath, a foul taste in your mouth, and probably going to lose your teeth. All right, some other issues are hyperkeratosis, which is leukoplakia. This is where you have white plaque or epidermal thickening of the mucosa on the cheeks, the palate, the lower lip, and the tongue. This is usually related to smoking or chronic irritation. You can also develop this with certain types of chemo or certain drugs, okay? And here it's a problem because the lesions can actually be a precursor to squamous cell carcinoma. All right, so there's that leukoplakia. We look for that white on the tongue. This could be called a super infection if you're giving someone certain broad spectrum antibiotics. Carcinoma of the oral cavity. So the most common one is squamous cell. These are common in people over 40 that smoke or have some sort of pre-existing leukoplakia or a history of alcohol abuse. This is a malignant tumor. It has a poor prognosis. It tends to be hidden and painless, and it will commonly occur in the floor of the mouth or on the sides of the tongue. The cancer initially looks like this white thickening and then develops either into a nodular mass, an ulcerative lesion. It will affect the regional lymph nodes and the nodes of the neck. Another one is lip cancer. This is usually obvious. It usually has a better prognosis. It spreads locally. It's common in people that smoke, especially pipe smokers. And you also have to worry about people that take things like snuff. They put that on the inside of their lip. And then Kaposi sarcoma, they like to ask about this one. We see this in our age patients. This is an opportunistic type of cancer, and they'll develop these brown or purple lesions in the palate of the mouth. All right, that last picture was, sorry, trying to go backwards here. Why didn't it let me go backwards? Let me stop it for a second. Let me go here. Sorry about that. All right, so that was the squamous cell carcinoma. You can see it there under the tongue, just in case I don't know if they show you pictures on the test, but they might. All right, salivadenitis. This is inflammation of the salivary glands. This can be infectious or non-infectious. So one of these that we'll see is the parotid gland. This could be mumps or infectious parotitis, okay, which causes bilateral swelling of the parotid gland. The bacterial infection can spread from the mouth. The parotid glands are just below and in front of each ear. You also have two other major pairs of salivary glands, the sublingual under your tongue and the submandibular under your jaw. So this swelling is known as parotitis. It's the parotid gland, so that should help you. Okay, it can occur in either one or both sides of the face. Different viruses can cause it. It's not always the mumps. And non-infectious parotitis can be developed in people that are debilitated or elderly people who lack adequate fluid intake and proper mouth care. They do have a vaccine available for it. The most frequent malignant tumor of the salivary gland is going to be mucoepidermoid carcinoma. I would worry more about the squamous cell and the Kaposi's. Those are the two I would expect them to ask you about. You should also know what mumps is. Oh, I'm going backwards again. Sorry, guys. Let me get it together here. It's a new computer, but it definitely works better than what we were struggling with a couple of weeks ago. Okay. All right. So this is the mumps. Look at the face. You can see how one side's a little puffier than the other. Okay. Again, that's from that parotid gland being swollen there. All right. Dysphagia. This is difficulty swallowing. It can be neurological issue, a muscular issue, or some sort of mechanical issue. And it can manifest as pain with swallowing, inability to swallow. Maybe they can't swallow their pills. They can't swallow liquids. Neurological issues would be things like infection, stroke, some sort of brain damage, and achalasia. Now, you have to know the definition for that achalasia, and that is failure of the lower esophageal sphincter to relax due to loss of innervation. So accumulation of food and dilation of the lower esophagus will happen as food enters the stomach, is delayed. Often chronic inflammation develops in the esophagus. Reflux of the food can lead to aspiration, especially when they lie down. And there's an increased risk for esophageal cancer in clients with long-term achalasia. Muscle impairment can also result from muscular dystrophies. So remember, achalasia is the failure of the lower esophageal sphincter to relax because of the lack of innervation. Muscular dystrophy is one of the things that we'll see that cause dysphagia from muscular issues, but you could also see that with like Lou Gehrig's disease. Mechanical obstruction. This includes congenital atresia. So here, the lower and the upper esophageal segments are separated, and we develop this blind pouch. Reflux can occur in the infant with congenital atresia, leading to aspiration. And usually there's a connecting fistula from one of the segments to the trachea, but not always. These babies are going to need immediate surgery to prevent aspiration and so that they can get fluid and nutrients in, because without the surgery, they won't be able to. Stenosis or narrowing of the esophagus can cause a problem. This can be developmental or acquired. And stenosis or strictures can result from scar tissue, from ingestion of things like corrosive chemicals. They can develop fibrosis from chronic inflammation or things like esophagitis. Mechanical obstructions are things like esophageal diverticuli. These are outpouchings of the esophageal wall. This can be from a congenital defect or inflammation. So food gets stuck in the pouch and it stops the flow of food down the esophagus, causes irritation inflammation, scar tissue. Later, the food can be regurgitated upward, and that can put the client at risk for aspiration. Signs of diverticuli are dysphagia, foul breath, chronic cough, and hoarseness. Sometimes ulcers form in the esophageal wall and bleed. Tumors could occur there as well, either externally or internally. And if it's a tumor on the outside of the esophagus, it can cause compression of the esophagus. So this is just showing you some of the ways dysphagia can occur. All right, you have a stricture or scar tissue that prevents the food from getting through. A tumor that's compressing the esophagus, or those pouches where the food can get stuck, which is called a diverticulum. So again, they can develop congenital atresia. That's your picture on the left. You see there's a segment missing. The food can't go to the esophagus here. The baby can regurgitate it and be at risk for aspiration. The other type is congenital tracheoesophageal fistula. This is where a fistula is formed between the esophagus and the trachea. So the food could go straight down, but it can end up in the lungs easily because of that fistula. Neurological damage. So that could be to any of those cranial nerves, 5, 7, 9, 10, and 12, or the achalasia, okay, where we lose peristalsis in the lower esophagus. So there's no innervation there. Esophageal cancer is primarily squamous cell cancer in the distal esophagus. Tumors here will either be circumferential, meaning they go all the way around, or they'll grow out of the lumen of the esophagus. Both can cause dysphagia. Esophageal cancer is associated with chronic irritation from chronic esophagitis, achalasia, hiatal hernia, alcohol abuse, and smoking. And it's poor prognosis typically. The signs usually occur late. Hiatal hernia, this is where part of the stomach protrudes through the opening or the hiatus of the diaphragm into the thoracic cavity. There's two types. We have a sliding one. That's the most common type. This is where a portion of the stomach and the the lower esophageal junction move above the diaphragm. And then in a rolling one, the paraesophageal hernia, part of the fundus or the stomach moves up through an enlarged or weak hiatus in the diaphragm. So these are on the next slide there. It's just showing you where the hernia occurs, okay? This is your hiatus here. Okay, so in the hiatal hernia, it's going to occur more up here, and then there's sliding and rolling. So with the hiatal hernia, food can become lodged in the pouch. That causes the mucosa to become inflamed. It causes reflux, and it can lead to chronic esophagitis. Symptoms are going to be heartburn or pyrosis, which is that burning in the chest, that sour taste, that reflux. They'll belch a lot. If they lay down, it's uncomfortable. All right, so they don't want to lay down after they eat. They don't want to lay flat. They can also have dysphagia because inflammation of the esophagus is occurring here, or there might be a mass of food in the pouch that's compressing the esophagus. So mild substernal chest pain after meals is a frequent complaint here. We can reduce this, through small frequent meals or avoiding lying flat. GERD, in this we have reflux with the gastric content going into the esophagus. It can occur with the hiatal hernia. The severity depends on the competence of the lower esophageal sphincter or the pressure on either side of the lower esophageal sphincter. For example, a decrease in lower esophageal pressure or increased abdominal pressure allows more of the gastric contents to go backwards into the esophagus. Delayed gastric emptying can also be a problem here. Episodes of reflux cause heartburn about 30 to 60 minutes after someone eats. Frequent reflux of gastric acid leads to inflammation and ulceration of the mucosa, and this can cause fibrosis or strictures to develop in the esophagus. Eliminating factors to reduce lower esophageal pressure include reducing your consumption of caffeine, fatty foods, alcohol, cigarette smoking, and certain drugs we can take, okay, to release the discomfort. Avoidance of spicy foods and medication can reduce the reflux and the inflammation. Gastritis, acute gastritis. Here the gastric mucosa is inflamed. It can be ulcerated or bleeding. We have acute gastritis. This is usually mild, or you can have chronic gastritis here. All right, with acute, this can come from infection, allergies to food, too much alcohol, taking aspirins or NSAIDs on an empty stomach, ingestion of some corrosive or toxic substance. Basic signs of GI irritation are going to be anorexia, nausea, vomiting, hematoemesis. Remember, that's the vomiting up of blood. This can indicate some sort of ulceration or bleeding in the stomach, epigastric pain or cramps. They can also develop fever and headache. Acute gastritis usually limits itself, and there is regeneration here of the gastric mucosa in a couple of days. If the person has severe or prolonged vomiting, they can become dehydrated, lose electrolytes, develop metabolic acidosis. With chronic gastritis, this is characterized by atrophy of the mucosa. So the mucosa is shrinking here, and they've lost those secretory glands. So remember what's there that's supposed to be secreting. The loss of the parietal cells. So parietal cells are supposed to be producing what?
Hydrochloric acid and I forget this one. There we go.
Intrinsic factor. There you go. So we have A, chlorohydria. Remember, A means without hydrochloric acid. We have a lack of the intrinsic factor, and therefore we're not absorbing B12. A lot of times with gastritis, they'll have an H. pylori infection. Okay? So we have to watch for that. Chronic gastritis is seen in people that have chronic peptic ulcers, people that abuse alcohol, and the elderly. Sometimes autoimmune disorders like pernicious anemia are associated with this type of gastric atrophy because it's chronic. Many cases are idiopathic, meaning the idiots don't know why we have it. Signs of chronic gastritis can be vague and include things like mild epigastric discomfort, anorexia, or avoiding or intolerance to things like spicy or fatty foods. These clients with chronic gastritis are at a higher risk for peptic ulcers and for gastric cancer. Gastritis is inflammation of the stomach and the intestines. Gastroenteritis also is an inflammatory process. This can be caused by infection or some allergic reaction to a food or a drug. Inflammation of the gastric mucosa will stimulate things like vomiting, whereas diarrhea typically comes from inflammation of the intestines and causes increased motility, impaired absorption, and in some cases, increased secretions. Nausea and abdominal cramps are usually present here, as well as fever and malaise. Some of these microorganisms are transmitted by fecally contaminated food and water. Most of them are mild or self-limiting. Some can lead to serious complications if the person is immunosuppressed or if we have a virulent strain. Food or waterborne illnesses involve a large number of cases. Sometimes we'll see entire communities affected or we'll have outbreaks. If we have a disaster, sometimes we'll receive instructions about the safety of the food and the water. Safe sanitation systems have to be put into place to prevent illness. Some infections might be seasonal or occur as epidemics, like a rotavirus. This can cause serious infection with vomiting and watery diarrhea, sometimes ulceration and bleeding in young children. Epidemics of viral gastroenteritis are common in daycare centers and institutions. By instituting things like hand washing and safe food handling, we can reduce these. Infection by C. diff or Clostridium difficile. We usually see this on patients that have been on broad spectrum antibiotics. Okay, so the gram-positive bacillus acts as a spore. Once it reaches the colon, the vegetative state occurs and it damages the intestinal mucosa, causing diarrhea that is sometimes mild, other times more severe. All right, this is just a few types of infections you can have. Okay, E. coli or traveler's diarrhea. So, this is when you're traveling through places, either other countries or sometimes just riding on the turnpike. And you notice that as you're traveling, you're coming back from a place and you already traveled down. Now you're coming back. And sometimes you'll develop diarrhea, right? This can be profuse, watery diarrhea, sometimes with blood or mucus. Sometimes they'll have vomiting and abdominal cramps with it. Salmonella you can get from undercooked seafood or eggs. Rotavirus, that's going to be mostly babies, okay? Norwalk virus can be in the older adult or children. The other ones I wouldn't really worry about too much. The Campylobacter, that's also from handling the raw food or seafood. So again, they're going to have diarrhea, nausea there. This is right from your book. All right, E. coli infections. Usually E. coli is harmless as a resident in the human intestines, but we can see some infected strains. Okay, so just know that it's normally harmless. Some types can stick to the mucosa and cause an enteral toxin and cause you to develop gastroenteritis. Mostly we'll see this in kids in the nursery school or in travelers, known as that traveler diarrhea. Peptic ulcers, these are caused by H. pylori. You need to know that. Most occur in the duodenum, but some can be in the antrum of the stomach. So if they're in the duodenum, they're called duodenal ulcers. If they're in the antrum, they're usually called gastric ulcers. Peptic ulcers are usually single, small, round cavities. They penetrate the submucosa. Once the acid or pepsin is able to penetrate the mucosal barrier, it exposes the tissue to damage. Some acid will diffuse into the gastric wall. Once acid or the pepsin gets to that point, then we're going to see an area of inflammation, erosion there. Okay, that can damage the blood vessel, cause bleeding to take place. So bleeding can involve loss of small amounts of blood, or they could even develop a massive hemorrhage here, depending on what size the blood vessel that's being damaged is. Again, this is just showing you the different places where different ulcers can develop. And based on where they are, what they'll be called. This is what a real one would look like. right, so we have damage to the mucosal barrier. That puts us at risk for inadequate blood supply. Factors can contribute to decreased resistance of the mucosa or excessive production of hydrochloric acid or pepsin. Impaired mucosal defenses are a more common condition in gastric ulcer development, and increased acid is usually the factor for the duodenal ulcer. Infection with H. pylori is found in most people with the peptic ulcer. They don't really know why, but it does secrete cytotoxins and enzymes that damage the mucosal defenses. The mucosal barrier is damaged, and so this can be caused by a few things: inadequate blood supply or vasoconstriction, and this can be caused by stress, smoking, or shock. Circulatory impairment in the older adult because of scar tissue or severe anemia. So we have a slower regeneration of the epithelium and a slower regeneration or production of mucus. Too much use of steroids, glucocorticoids, NSAIDs, or aspirin, or alcohol, which can break down the mucus layer, or atrophy of the gastric mucosa from some sort of gastric or chronic gastritis or gastric issue. We can also have increased acid pepsin secretions. These are associated with increased gastrin secretion, increased vagal stimulation, increased number of acid pepsin secretory cells. This is caused by genetics. Increased stimulation of acid pepsin secretion by alcohol, caffeine, or other foods. Interference with the feedback mechanism that reduces the acid pepsin secretion when the stomach is empty, or rapid gastric emptying. Severe or prolonged stress can affect both sides of the balance, reducing the blood flow and the motility to the mucosal area. It can cause chyme to stick around there and be slow to move. Stress can promote behaviors that are implicated in ulcer development. So increased caffeine and alcohol intake, cigarette smoking, altered eating patterns, all can lead to these ulcers. Healing of the ulcer is hard because the lesion cannot be isolated from the irritant. The granulation tissue will form and sometimes break down because it's subject to damage from that acidic chyme. It requires a longer time for healing here, so more scar tissue is able to develop. The ulcers tend to reoccur because of predisposing factors that remain, or the scar tissue itself interferes with blood supply to the area. The ulcer can erode a blood vessel, causing hemorrhages. Rupture of small blood vessels can cause a continued loss of a small amount of blood, and this will usually show up as a cold blood in that stool. If they have a lot of bleeding, they'll probably have the amount of emesis because the tissue is going to be irritated there. So hemorrhage might be the first sign of a peptic ulcer for some people. Another complication that can occur here is perforation if the ulcer erodes completely through the wall and allows chyme to enter the peritoneal cavity. These clients can develop what we call chemical peritonitis. I would know that. Third is obstruction of the digestive tract, which can later result in scar tissue around the pyloric or duodenum area, particularly people with protracted or recurrent ulcerations. Peptic ulcers are more common in men than women, more common in men than women, and genetic factor is associated with people with type O. So if you have type O blood, you're more at risk for these peptic ulcers. They don't know why, but they just know that they are. And then gastric ulcers are more common in the older adult, especially those with scar tissue and those who take a lot of NSAIDs or any kind of medication that causes damage to the stomach. All right, so what are we going to see with these peptic ulcers? Infection with H. pylori is a major cause. They're going to ask about that. Epigastric burning or aching pain. This happens 2 to 3 hours after the meal. So a lot of times what will happen is 2 to 3 hours after the meal, they'll wake up with this epigastric or burning pain. What do you think they do? They'll either eat or they'll drink like Maalox. Okay? And that can help relieve the pain. If they eat spicy foods during a meal, that can initiate pain right away. Heartburn, nausea, vomiting, and weight loss can occur. Vomiting is more likely to happen after alcohol intake or with particular irritating foods. In some patients, weight gain because they're eating, trying to relieve that pain that couple of hours after a meal. And then they can develop iron deficiency anemia, okay, because of the loss of blood. Stress ulcers, we see these with high stressful things. So like a major burn, a head injury, sepsis. Ulcers in the presence of burns are called curling ulcers. So usually when someone comes in with a major burn, we'll start them right away on proton pump inhibitors to prevent this curling ulcer. Okay, proton pump inhibitors to prevent this ulcer. With head injuries, they're called Cushing's ulcers. And others may be referred to as ischemic ulcers. Multiple ulcers, usually gastric ulcers, can form within hours of the event as the blood flow to the mucosa is greatly reduced, leading to a reduced secretion of mucus and epithelial regeneration. If the mucosal barrier is lost and acid gets into the mucosa, then they can develop these ulcers. In people with Cushing's ulcers, increased vagal stimulation of acid secretion often occurs. The first indication of the stress ulcer is usually hemorrhage. All right, gastric cancer. This comes primarily from the mucus cells. Most tumors are in the antrum or the pyloric area, some in the less curvature of the stomach. Adenocarcinoma occurs most frequently. This lesion is most often an ulcerative type, and it forms an irregular crater with a raised margin. Other types of gastric cancer can infiltrate the gastric wall, causing thickening or appear as a mass or a polyp. Early gastric carcinoma is a lesion confined to the mucosa and submucosa. Advanced gastric carcinoma involves the mucolaris layer. Eventually, the tumor extends into the serosa, spreads to those lymph nodes, into the liver, the ovaries. Gastric cancer is asymptomatic early on and not usually diagnosed till well advanced. So prognosis is poor here. Diet seems to be a key factor, especially those smoked foods, foods with nitrates, okay, like hot dogs. Genetic influences also play a role here. These clients usually will have chronic atrophic gastritis or polyps, and manifestations are usually vague or mild till the cancer is more advanced. Initial signs are going to be anorexia, feelings of indigestion, epigastric discomfort, feeling of fullness. Please put yourself on mute. Dumping syndrome. This is where we have a loss of gastric emptying control. So we're not able to control how quickly that the gastric emptying is occurring. This can happen to people that have had gastric resections because the pyloric sphincter is removed. Remember, that's supposed to control how much is going through there into the duodenum. Large quantities of ingested food are rapidly dumped into the intestine. This can also happen to babies, okay, that have lost part of their intestines. The storage in the stomach includes the appropriate dilution of chyme by the gastric secretions. That part doesn't happen in dumping syndrome. They have this hyperosmolar or chyme, and it draws a lot of fluid, and it draws it from the blood vessels into the intestines. This causes additional intestinal distension, and it increases the intestinal motility. So these clients will have changes shortly after meals that include abdominal cramping, nausea, and diarrhea. They'll develop hypovolemia with dizziness or weakness, rapid pulse, and sweating because of the increase of that fluid being drawn into the intestines. So that's going to cause a decrease in blood pressure, which can lead to anxiety and syncope. Also, we'll see with dumping syndrome, hypoglycemia 2 to 3 hours after they eat because the body takes in the food rapidly. Okay, that causes the blood glucose levels to go up. But then the fluid leaves. It causes the insulin to be released, okay, and the blood glucose levels to go up, both. The problem is the food is going to leave the stomach. It's not going to be absorbed. Now we have all this insulin released, but no food there to absorb. So that causes the blood glucose level to drop because there's no nutrients there for us to absorb. Any questions on that? Rebound hypoglycemia can occur several hours after they eat with tremors, sweating, and weakness. So we can try to resolve this by having them eat small, frequent meals high in protein and low in simple carbs, no fluid with the meals. Again, you eat. Okay, we have a decrease in the capacity of the gastric area or a loss of the pyloric sphincter. That causes a large amount of undiluted chyme to be dumped in the small intestines. A lot of fluid is now pulled in there to dilute that chyme that's very hypertonic. So that causes hypovolemia because the fluid's being pulled from other vessels in the body into the intestines. So they'll develop hypovolemia, a decrease in blood pressure, faint, weak pulse, dizziness, tachycardia. They can also have pain, cramps, nausea, and vomiting. Again, we're going to have hyperglycemia at first because the food's there. So the food's there, the body becomes hyperglycemic. This causes an increase in the insulin. But the food doesn't stay there, it gets dumped out quickly. So because of that, a couple of hours later, they're going to develop hypoglycemia, weakness, tachycardia, pallor, because the body didn't actually absorb those nutrients, but it still produced the insulin. Pyloric stenosis, this is where we have narrowing and obstruction of the pyloric sphincter. Babies can be born with this, or it can be acquired later on in life because of scar tissue. In the congenital form, the pyloric muscle is hypertrophied, and it looks like a hard mass in the abdomen. People call it olive-shaped. Usually, the first appearance of this is that projectile vomiting several weeks after birth. Okay, so the baby in the beginning is okay, but as the first episodes of regurgitation of some food, and then eventually they develop that projectile vomiting as soon as they eat. Small stools here will be small and infrequent. The baby is not going to gain weight. They're going to be dehydrated. They're going to be irritable, and they will need surgery. All right, some other disorders we'll see, cholelithiasis. This is the gallstones, okay? So you need to know that, all right? And these are made from calculi that form in the bile. Cholecystitis, which is inflammation of the gallbladder and the cystic duct. cholangitis, which is inflammation related to infection of the bile ducts, and choledocholitis. This is obstruction by gallstones of the biliary tract. Now, usually if you have an obstruction, you'll know it with gallstones because you're going to have that colicky pain. Gallstones are made out of different things. Cholesterol stones, pigments, they can be mixed. Most of them are made from the cholesterol stones. Small stones are usually asymptomatic and they don't cause any problem. But larger stones can be very painful. The gallstones can vary in size, okay? And then if E. coli or enterococci gains access to the gallbladder through the sphincter of Oddi, that can cause an infection. If the stone obstructs the bile or the common bile duct, colic will develop, and that's going to cause severe muscle contractions, trying to get rid of the stone. So that's what we call colicky pain. Obstruction of the biliary system at the sphincter of Oddi can also cause pancreatitis. And this can also be because of the pancreatic secretions being backed up. Gallstones are going to form whenever the bile has a high concentration of something like cholesterol, or if we don't have enough bile salts. The gallstones can cause irritation and inflammation, and that is what we call cholecystitis. Who's at highest risk? Women are more likely. People with high cholesterol levels, people that are obese, people with multiparity, meaning they've given birth to multiple children, use of oral contraceptives, hemolytic anemia, which is what? What are the two hemolytic anemias? Thalassemia and sickle cell, right? Alcoholic cirrhosis and biliary tract infections. Larger calculi can obstruct the duct at any time and cause severe waves of pain known as biliary colic in the upper right quadrant of the abdomen, or epigastric pain that radiates to the back and right shoulder. If pain continues, jaundice can develop as the bile backs up into the liver and the blood. There's also a risk for a ruptured gallbladder if the obstruction continues. Acute cholecystitis is associated with some degree of obstruction and inflammation. So, they might have to have the gallbladder taken out. Severe pain is usually seen after they eat this large fatty meal, and they'll develop fever, leukocytosis, and vomiting. The pain can occur for some time, and it can get worse. And then if the stone is passed, it can decrease. So chronic cholecystitis manifested by intolerance to fatty foods, excessive belching, bloating, and mild epigastric pain. All right, next is jaundice. We can have prehepatic jaundice, intrahepatic jaundice, or posthepatic. Jaundice or icterus is the yellow color of the skin and the other tissue that comes from the high level of bilirubin in the blood. Usually we see the first color change in the sclera, or the white of the eye. Bilirubin is a product of hemolysis. So as the red blood cells break down, that bilirubin is produced from the breakdown of the red blood cell and the hemoglobin. Jaundice or hyperbilirubinemia can be caused by different disorders. So we can have prehepatic jaundice. This is from excessive destruction of the red blood cells, and it's characteristic with those hemolytic anemias like sickle cell or thalassemia. The liver is unable to handle the additional bilirubin. Physiological jaundice of the newborn happens about 2 to 3 days after they're born. Intrahepatic jaundice occurs in individuals with liver disease, like hepatitis or cirrhosis. It's caused by an impaired uptake of bilirubin from the blood and a decrease in the conjugation of the bilirubin by those liver cells or hepatocytes. And then post-hepatic jaundice from the obstruction of the bile flow into the gallbladder or the duodenum, causing a backup of the bile into the blood. This can be caused by congenital atresia of the bile ducts, obstruction because of a gallstone, inflammation of the liver, or tumors. All right, so bilirubin has to be conjugated. If it's direct or conjugated, we can measure it in the blood. Total bilirubin is measured in the blood. Total bilirubin minus direct bilirubin tells us how much indirect or unconjugated bilirubin that we have. And we're looking at this because if we have unconjugated bilirubin, okay, these levels are elevated in prehepatic jaundice. In posthepatic jaundice, we would have increased amounts of conjugated bilirubin. So bilirubin, remember, can cross the blood-brain barrier and do damage. So we want to be careful with bilirubin levels in the body. Bilirubin gives bile its color. It also colors your poop, but it might build up in your blood if your liver is struggling to process it, if your biliary system isn't working, or if your body is breaking down too many red blood cells. All right, so if it's conjugated, then your liver has processed it. If it's unconjugated, then it's not water soluble. It will bound to the protein in your blood, and then it's supposed to go to your liver so that the liver can break it down, conjugate it and break it down. If it's unconjugated and in your blood, it can be dangerous. All right, so we talked about all these. Any questions on any of those? All right, the liver has a couple of areas of sources of blood. The portal vein can bring in nutrient-rich blood from the digestive system. And then you have the hepatic artery, which carries oxygenated blood from the heart. These vessels divide into small capillaries. They go into these lobules, and those are the functional units of the liver. And that's where all those hepatocytes or those liver cells we talked about earlier are located. And there are 3 hepatic veins there also, which help remove the blood from the liver. Now, hepatitis, this is inflammation of the liver. It can be idiopathic, so like you have a fatty liver. And this could be also from a viral hepatitis. You could have a local infection. So these types of hepatitis, we might not know the cause. All right, so fatty liver or infection from like a viral hepatitis, we might not know the cause. It can come from infections other places in the body as well, or from drug or chemical toxicity. So sometimes people will develop drug-induced hepatitis. It's a virus. Okay, so viral hepatitis impairs the function of the liver cells or those hepatocytes. It can cause inflammation and necrosis, obstruction of the blood and the bile flow in the liver, and impair the liver's ability to function. More severe inflammation and necrosis can cause obstruction of the blood and the bile flow in the liver, impaired liver cell function. All right, so the liver itself has good functional reserve. It has regenerative powers. A number of viruses can affect it. So hepatitis usually comes from hep A, which I call oral fecal, okay? Because you spread it from your fecal area through your fingers into your mouth. So we'll see this at like daycare centers, dirty seafood. Hep B, which be in all your fluids, everything wet except sweat. So this can be in your saliva, your blood. Hepatitis C, I'll see your ass later because you're probably engaging in things like risky sex and IV drug shooting. And then Hep D and Hep E, which are additional takeoffs, okay, of the other types of hepatitis. The liver cells are damaged in two ways, either by the action of the virus, like in Hep C, or by some cell-mediated immune response to the virus, like in Hep B. Either way, injury results in inflammation and necrosis in the liver. So the liver is going to look swollen. There may be diffuse necrosis present. This can cause biliary stasis, backup of bile in the blood. Some cases, they'll be slow to develop the signs and symptoms, and in other cases, it can fully involve the liver, and they can have massive necrosis and liver failure. Again, I just went through the basic ways that these are spread, okay? So any questions there about how they're transmitted? All right, hepatitis B, again, this is, if you have a Hep B, you could get this. And then Hep E usually is oral fecal also, but usually we see that in more of the third world countries. All right, so what are we going to see in all hepatitis? All right, so we'll see the pre-icteric or the prodromal stage. This is where the jaundice sets in. I'm sorry, we'll see the pre-icteric or the prodromal stage, and then the icteric or the jaundice stage, and then the post-icteric stage. So the pre-icteric stage can be slow. In this stage, they're developing the fatigue, the malaise, the anorexia, nausea, and general aches and pains, especially in the muscles. Sometimes fever and headache. The icteric stage is when they start to develop the jaundice. So here, they may have biliary obstruction. The stools are start to become light in color. Urine becomes dark, and skin becomes itchy or pruritic. And the liver will become enlarged. Blood clotting times can be impaired here. The post-icteric or recovery stage is marked by a reduction in signs. That'll happen several weeks later. It takes a long time for these infections to go away. All right, there's no method of destroying hepatitis viruses in the body, so we use supportive measurements. With cirrhosis, we have progressive destruction of the liver, leading to liver failure. This can be classified by structural changes that cause the disorder. Cirrhosis can also be linked to specific underlying disorders, like congenital problems or inherited metabolic problems. But the four major categories of cirrhosis are alcoholic liver disease, biliary cirrhosis, which is more associated with an immune disorder and obstruction of the bile flow, like cystic fibrosis, post-necrotic cirrhosis, linked with things like chronic hepatitis or long-term exposure to toxins, or metabolic, which is usually caused by some sort of storage disorder like hemochromatosis. Cirrhosis is a disorder that demonstrates extensive diffuse fibrosis, loss of lobular organization. We'll have nodules of regenerated hepatocytes. Those are those liver cells, and they're present but not functional. And this is because the vascular network and the biliary ducts are destroyed or damaged. Even if we remove the cause, it will continue to break down and cause fibrosis that interferes with the blood supply to the liver tissue. The bile can back up. Initially, the liver is enlarged, but eventually they become small and shrunken as fibrosis proceeds. This can cause degenerative changes. They're usually asymptomatic until the disease is well advanced. So we'll have extensive diffuse fibrosis that interferes with the blood supply, loss of the lobe organization, degenerative changes. With alcoholic disease or portal cirrhosis, there's several stages. Usually, we're going to see that fatty tissue. Okay. The second stage, the alcohol hepatitis, will have inflammation and cell necrosis and fibrosis. That's going to affect the liver's ability to function. If the person continues to drink, all right, then they can actually end up in liver failure, encephalopathy, because proteins aren't being broken down there and ammonia is developing, and death. And usually once the fibrotic tissue replaces the normal tissue, they're in either third stage or end stage cirrhosis. And this is going to impair also that portal hypertension or that portal vein system and cause them to develop portal hypertension in that portal vein system. So the initial stage, we see the fatty liver develop and enlargement of the liver. This is usually asymptomatic, and if we stop drinking, we can reverse it. The second stage, alcoholic hepatitis, will have inflammation and cell necrosis and formation of that fibrous tissue. This is not reversible. And then the third stage, where we're in end-stage cirrhosis, and the fibrotic tissue is now taken over the normal tissue, and we have little function. So then as a result of that, okay, the liver's not working. Now we're going to have a problem with blood and bile flow in the liver, a lot of functional losses, decreased removal and decreased removal and conjugation of the bilirubin, decreased production of the bile, an impairment in digestion and absorption of the nutrients, especially the fats and the fat-soluble vitamins, a decrease in those blood clotting factors, a decrease in those plasma proteins like albumin, and impaired glucose or glycogen metabolism. So a lot of problems there. Other things we'll see is decrease in activation of hormones like aldosterone and estrogen, decreased removal of toxins in the blood like ammonia and drugs, bile backing up into the liver, leading to obstructive jaundice, blockage of flow through the liver, causing portal hypertension, inadequate storage of iron and vitamin B12, reduction in the amount of bile going into the intestines. That's going to interfere with digestion and absorption. And then esophageal varices, that's because of that portal hypertension. So these esophageal vessels are actually bleeding in that hepatic portal system there. They'll develop ascites, extra fluid in that peritoneal cavity, and that's going to cause abdominal distension and pressure. So this next slide is showing you about those bleeding esophageal varices. All right, so this is just showing you again about the portal hypertension, the increased hydrostatic pressure there, a decrease in the production of albumin, a decrease in that osmotic pressure. That's going to cause that fluid to develop in the belly there and cause ascites. Remember that the albumin helps keep the fluid in the vessels. So if we lack albumin, that's going to cause the fluid to go into the abdominal area and cause that ascites. We have a decrease in the blood volume, a reduction in the activation of aldosterone and ADH. Okay, so we're going to have a difficult time with fluids there in general. So in the beginning, the manifestations might be mild or vague. As it progresses, they'll develop fatigue, anorexia, weight loss, anemia, diarrhea, dull aching pain in the upper right quadrant. As it progresses, ascites, that peripheral edema, increased bruising, those esophageal varices from those bleeding veins in that portal hepatic system, jaundice, encephalopathy, because now the proteins aren't being broken down, that ammonia is going to the brain, the red blood cells are being broken down and causing that jaundice. Also, it's going to affect those sex hormones. And complications involve ruptured esophageal varices. This can lead to hemorrhages, shock, and hepatic encephalopathy. Again, all the things that can happen to you right there in a nutshell. Liver cancer, hepatocellular carcinoma. Secondary tumors are common in the liver. Primary malignant tumors are not. The common primary tumor is hepatocellular carcinoma that develops in cirrhotic livers. Cirrhosis can be secondary to metabolic disorders or hepatitis. Tumors can also be from prolonged exposure to carcinogenic chemicals. Cirrhosis could be secondary to metabolic disorders or hepatitis. Secondary or metastatic cancer often comes from areas that are served by the hepatic portal veins or those that spread along the peritoneal membranes. The signs of liver cancer are usually mild, but they include anorexia, vomiting, fatigue, weight loss, hepatomegaly, portal hypertension, and splenomegaly also, and paraneoplastic syndrome, which is what? Who knows? Nobody's participating anymore?
Abnormal growth of cells.
So paraneoplastic syndrome causes that tumor to produce substances, hormones, right? Like erythropoietin, estrogen, insulin. You guys got to know these terms. They are going to test you on them. All right, acute pancreatitis. We're getting close to the end. This is a huge chapter. But I want to try to cover it all for you so you understand it. All right, acute pancreatitis. This is going to be inflammation of the pancreas, and it's usually from autodigestion of the tissues. And it comes from pre-activation of those pancreatic proenzymes like trypsinogen, chymotrypsinogen. The activated enzymes trypsin and proteases, amylase, and lipase will digest the pancreatic tissue, causing massive inflammation, bleeding, and necrosis. It can occur in acute or chronic form, and it is considered a medical emergency, acute pancreatitis. Pancreas itself is delicate, and it lacks the fibrous capsule, and destruction by the trypsin and other enzymes will destroy the pancreas. Damaging products like cytokines, prostaglandins that are released by the tissue during necrosis can cause widespread inflammation of the peritoneal membranes or chemical peritonitis. The inflammatory response causes vasodilation, increased capillary permeability, and that can lead to things like hypovolemia and circulation collapse, circulatory collapse. These clients are going to have severe pain because of the autodigestion of the nerves and the inflammation, and it can lead to a neurogenic type of shock. Chemical peritonitis usually results in a bacterial peritonitis as the intestinal bacteria escape through those permeable membranes. Septicemia or sepsis can result from the escape of the bacteria and the toxin from the intestines into the general circulatory system. Other complications can cause death, include adult respiratory stress syndrome or acute renal failure. Many factors precipitate acute pancreatitis, but the two major causes of acute pancreatitis are gallstones and alcohol abuse. I would know that. Gallstones will obstruct the flow of the bile and the pancreatic secretions into the duodenum. This can cause reflux of the bile into the pancreatic duct, activating the trypsinogen. Alcohol stimulates an increased secretion of pancreatic enzymes to contract the sphincter of body, blocking the flow. Sudden onset of acute pancreatitis often follows a large intake of food or a large amount of alcohol. Signs and symptoms of acute pancreatitis are severe epigastric or abdominal pain radiating to the back. Pain increases when you put yourself in a supine position. So these clients like to lie in fetal position because of that. Signs of shock will be seen: low blood pressure, pallor, sweating, rapid weak pulse, inflammation, hemorrhage causing hypovolemia, low-grade fevers, infection, and abdominal distension, and a decrease in the bowel sounds if they develop the peritonitis. We'll also see a decrease in peristalsis and paralytic ileus. All right, so we have some sort of precipitating factor like alcohol or that large mill. It activates the pancreatic enzymes inside the pancreatic ducts. That causes autodigestion or destruction of the pancreatic tissue from the trypsin, the amylase, the lipase. The enzymes are able to leak into general circulation, and that can cause shock, DIC, respiratory distress. The activated enzymes leak into the peritoneal cavity, and this can cause damage there, severe pain, hemorrhage, shock, hypovolemia. Next is pancreatic cancer, and this is increasing in incidence. The major risk factor is cigarette smoking. Pancreatitis and dietary factors are also implicated here. The common form is adenocarcinoma, which comes from the epithelial cells in the duct. A tumor at the head of the pancreas usually causes obstruction of biliary and pancreatic flow. That can lead to weight loss and jaundice. Those are some of your early signs. Cancer of the body and the tail of the pancreas frequently remains asymptomatic until it's well advanced. The pain will become more severe as cancer progresses and starts to erode the tissues. Unless the tumor is diagnosed early, it can be removed surgically. It is not usually diagnosed until late if it occurs in the body and the tail. Metastasis can occur early. The mortality rate is about 95%. Both, I have two uncles that died from this and very quickly, okay? My one uncle was in his early 50s. He got this in the summer and he died the day after Christmas. So the first clue was he developed diabetes. And then he got what he thought was constipation. By the time they figured out it wasn't constipation and it was the cancer, he was already well on his way to dying. They diagnosed him with the actual pancreatic cancer in October. He weighed about 255 pounds when he got it in the summertime. By the time he died, he was lucky if he weighed 95 pounds. All right, so we have liver failure here from the hepatobiliary obstruction, and that's typically the cause of death. All right, let's look at these ones. Celiac, this is malabsorption. It mainly occurs in childhood, okay? And it's because of the malabsorption and the inability of the body to break down gliadin. And gliadin is a product of gluten. So the body can't break down this gliadin. It's usually genetic. And we have a defect in the intestinal enzyme that prevents the digestion of gliadin. Again, a product of gluten. Gluten is a protein that's made out of certain grains. So for these kids, we say they can't eat brow, barley, rye, oats, wheat. We call that brow. And what will happen is the villi, remember those little finger-like projections for the villi are responsible for absorption. These villi become atrophy. We have a decrease in enzyme production, less surface area available for absorption of nutrients. So this is a malabsorption, malnutrition disorder. These people will develop with the typical manifestations of steatorrhea, which is that fatty, smelly stool, muscle wasting, failure to gain weight, irritability, and malaise. First signs usually appear as cereals are added to the diet. So we'll see this around 4 to 6 months old. Crohn's disease, also malabsorption. Okay. Causes for Crohn's and ulcerative colitis are genetics usually. There's a high familiar incident, and these are both considered irritable bowel diseases or inflammatory bowel diseases. I'm sorry. There are 2 genes, if defective, that are linked to Crohn's. And many people that have ulcerative colitis, they have immunity disorders in the body. So they might have things like iritis, ankylosing spondylitis, arthritis. There are a lot of similarities between Crohn and ulcerative colitis. Both occur in males and females. Crohn's usually happens during adolescence, whereas ulcerative colitis is going to be more in your 20s or 30s. They're characterized by remissions and exacerbations. And they're considered a lot of diversity in the way people will present with this and maybe even the way that it's treated. All right, so let's break them down. Crohn's can affect any area of the digestive tract, but mostly small intestines. So that's why it's malabsorption. That's what's taking place there is absorption. It'll have skip lesions. So this goes throughout the intestines, okay? These little skip lesions. Inflammation occurs in the mucosal layer. So it causes shallow ulcers. The ulcers cause these fissures to form, and it could cause thickened areas to form. And it makes the intestines look like a cobblestone appearance. We'll have inflammation and fibrosis that affect all the layers of the wall. This can cause a thick, rigid, rubber hose-like wall with a narrow lumen. Granulomas are indicative. The damaged wall impairs the ability of the small intestine to process and absorb food. Inflammation stimulates intestinal motility, decreasing the amount of time the food is available for digestion or absorption. So for Crohn's, we have interference with digestion and absorption, hyperproteinemia, which is lack of that protein, those albumins, avidominosis, malnutrition, possibly steatorrhea. They can develop adhesions and loops, form those fistulas. This is going to cause delayed growth and sexual maturation for kids. And again, they can have remissions and exacerbations. But this is a malabsorption issue. Okay, ulcerative colitis, this starts in the rectum. It progresses in a continuous fashion, proximally through the colon. It doesn't involve the small intestines. That's why there's no absorption issue. The mucosa and submucosa are inflamed. They become edematous. Ulcerations develop. Granulation tissue will form, but it's vascular and fragile and it bleeds easy. When the ulcers grow together, large areas of mucosa become exposed to the erosion. The tissue destruction interferes with absorption of fluid and electrolytes in the colon. They can develop a toxomegacolon. This can impair peristalsis, lead to obstructions, dilate the colon. Toxic megacolon can be a medical emergency. This is where we have non-obstructive dilation of the colon, and it's usually associated with some sort of systemic toxicity. The ulcerative colitis is putting the person at an increased risk for colorectal carcinoma. They'll have diarrhea, frequent watery stools, blood and mucus in the stools, sometimes cramping pains, tenesmus, which is persistent spasms of the rectum associated with a feeling of needing to defecate, rectal bleeding, severe iron deficiency anemia, fever, and weight loss. Irritable bowel syndrome. This is based on primary symptoms. And here we can have abdominal pain, discomfort, changes in bowel habits. There's different types, abnormal GI, motility, and secretion. So here we have a rapid transit time where the feces move through quickly. Some people have issues with constipation and bloating, and they can go back and forth. It can be from food allergies or intolerance, overgrowth of flora, or psychological factors like emotional stress. So usually with irritable bowel syndrome, they're going to have lower abdominal pain, diarrhea, constipation, alternating with diarrhea, bloating, gas, fecal urgency. Appendix, okay? The main cause of this is the fecal lip, and that's a stony piece of poop. You got to know that. All right, obstruction of the appendiceal lumen by the fecal lip or this hard stony mass of feces. It can also occur from a gallstone or foreign matter or twisting of the vessels there. Here, fluid usually builds up in the appendix. The bacteria starts to grow. The appendiceal wall becomes inflamed. Purulent exudate forms. The appendix becomes swollen. Blood vessels compressed. The congestion and pressure leads to ischemia and necrosis of the wall. And increased permeability, which means things can now slip through easier. The bacteria and the toxins can now move through the wall. And this can cause the patient to develop bacterial peritonitis. An abscess can also form here. We'll see increased necrosis and gangrene in the wall, increased pressure in the appendix itself. The wall of the appendix might look black. If it ruptures or perforates, then the contents dump into the peritoneal cavity. This can cause generalized peritonitis, and that can be life-threatening. So sometimes appendicitis develops silently. These clients can develop general peri-umbilical pain related to inflammation and stretching of the appendiceal wall. So you'll see like a blue area around the umbilicus known as Colin's sign. Pain can become severe and localized in the lower right quadrant of the abdomen. Lower right quadrant tenderness develops classically at McBurney's point between the umbilicus and the iliac crest. If rupture occurs, the pain usually subsides temporarily as pressure is relieved. Pain reoccurs as a steady, severe abdominal pain. Peritonitis will develop. Low-grade fever, leukocytosis occur as inflammation develops. Signs would be onset of peritonitis, rigid board-like abdomen, tachycardia, and hypotension. So again, they'll have general peri-umbilical pain related to the inflammation, nausea and vomiting. Pain becomes more severe and localized in the lower right quadrant, and lower right quadrant tenderness developed classically at McBurney's point. After rupture, the pain subsides temporarily as the pressure is relieved. The pain will reoccur as steady, severe abdominal pain as peritonitis develops. Low-grade fever, leukocytosis as inflammation develops. Signs are going to be rigid, board-like abdomen, tachycardia, hypotension. All right, diverticuli. These are problems related to development of diverticula, and the diverticula can be congenital or acquired. This diverticulum is a herniation or outpouch of the mucosa through the muscle layer of the colon wall. It's usually asymptomatic. Diverticulosis is asymptomatic diverticular disease. Diverticulitis is inflammation in the diverticuli. So the diverticuli forms at these gaps there, and there's pouches there, okay? It's a weaker area of the wall where it bulges whenever pressure is increased. And inside the lumen of the intestines, we have these strong muscle contractions. Potential complications include intestinal obstruction, perforation with peritonitis, and abscess formation. In many diverticuli, the disease itself remains asymptomatic. So they have mild discomfort, diarrhea, or constipation. And a lot of times we attribute it to other things. With diverticulitis, we'll have inflammation related to stasis of the feces in the pouches. This develops in the diverticuli, lower left quadrant, cramping or steady pain, tenderness with nausea, vomiting, a slight fever, elevated with white blood cell count. All right, so that's just trying to show you the little pouches there. Next is colorectal cancer. This is a high lethal cancer. Happens in people over 50. Second leading cause of cancer-related deaths. Most can be prevented. So we look for things like polyps, malignancies. Malignant tumors are rare in the small intestine. Most of these tumors develop from adenomatous polyps. Adenomatous. Yeah, let me say that again. From adenomatous polyps. And there's diverse types. So a polyp is a mass that protrudes into the lumen. Many polyps represent genetic abnormalities. As the polyps increase in size, they carry an increased risk of dysplasia and malignancy. Adenocarcinomas are distributed equally in the right ascending colon or the left descending colon, the distal sigmoid colon, and the rectum. And lesions in the right colon are increasing and harder to diagnose. This cancer occurs primarily in people over the age of 50. Those with polyps, long-term ulcerative colitis, genetic history, and some environmental factors like eating diets that are low in fiber and high in fat. So diets that are high in fat, sugar, and red meat produce carcinogenic substances and are typically related to this type of cancer. Most of these carcinomas are asymptomatic until they're well advanced. We'll see unexplained changes in bowel habits, like alternating episodes of diarrhea and constipation, bleeding in the way of occult blood or melena with that tarry black stool. If it's frank red blood and mucosa on the surface, the stool is usually from the red bleeding on the stool is usually from some lesion in the rectum. It's not usually cancer associated. Most of these adenocarcinomas release CEA into the blood. So this is a cancer screening tool that we can use to look to see if they're at risk for developing this type of cancer. So it's called CEA. We can test the blood for it. All right, so initial signs, again, are going to be changes in the bowel habits, bleeding. Remember, most of the large intestines is made up of the colon. So if you look on this slide, this shows you how the colon ascends, where it starts at, okay? I talked about it multiple times. Now you can see a picture of it there. The first section is the ascending colon. It starts with a pouch called the cecum. When undigested food comes in from the small intestines, it will continue upward on the right side of the abdomen. The second section is the transverse colon. It goes across the body from the right to the left. Third is descending colon. It goes down on the left side. And fourth is the sigmoid colon because of its S shape. And it joins the rectum, which then connects to the anus. The ascending and transverse sections are the proximal colon. The descending and sigmoid are the distal colon. The carcinomas can manifest differently. For example, they could be circumferential or annular constrictive, where it's like a napkin ring growth, where it's circular. These are common in the left colon. For example, annular lesions in the recto-sigmoid colon are more common, where the fecal mass is relatively solid, and this causes partial obstruction with dilation of the proximal colon. So we'll see things like cramping pains or ribbon type of stools. Cancer in the right colon, the fecal matter is going to be more liquid, and it doesn't usually cause an obstruction, but we will see things like fatigue, weight loss, iron deficiency, anemia. And of course, the bleeding is indicated by the occult blood or the melena. And it usually will come from that proximal colon if you have that dark, tarry colored stool. Most colorectal cancers start at the inner lining of the colon or the rectum, and people will develop these polyps. Okay, so that's why they like to do the colonoscopy. Go up there, look for the polyps. They can take a piece of the polyp and look at it to see if it's considered cancerous. So that's what they're going to do. All types of carcinoma will invade the wall, the mesentery, the lymph nodes, and metastasize to the liver here. And staging is based on the degree of local invasion, lymph node involvement, and the presence of distant metastasis. So this is for those adenomatous polyps, okay? The polyps can change into the cancer. And again, they'll invade the wall, the mesentery, the lymph nodes, and metastasize to the liver. People can also develop intestinal obstructions where things aren't moving, okay, through the intestines. And they're common and occur more rapidly in the small intestines because it's smaller lumen. Depending on the cause and location, obstruction can be manifested as an acute problem or a gradually developing one. For example, twisting of the intestines could cause total obstruction, whereas a tumor may cause progressive obstruction. We can have mechanical obstruction, which would be from a tumor, adhesions, hernias, or other tangible obstructions, or a functional obstruction, which comes from neurological impairment like spinal cord injuries, lack of propulsion in the intestines. These are often referred to as paralytic ileus. They can both manifest differently, okay, and require different treatments. Gases and fluids can accumulate in the intestines, causing it to distend. Gases are from swallowed air, but can also be from bacterial activity. This can cause strong contractions, trying to remove the content, increase in pressure in the lumen, can lead to more secretions entering the intestine and compress the veins in the wall, preventing absorption as the intestinal wall becomes edematous. The intestinal distension can cause things like persistent vomiting and losses of fluid and electrolytes because of that. There's also no way to reabsorb the fluid and electrolytes, and hypovolemia can quickly result. If we don't remove the obstruction, then the intestinal wall will become ischemic and necrotic as the arterial blood supply to the tissue is reduced because of the pressure. Compression on all the veins in the walls can cause the intestinal wall to become ischemic and necrotic as the arterial blood supply is reduced. It can also lead to problems with absorption. The intestinal distension leads to persistent vomiting, additional loss of fluid and electrolytes. There's no opportunity to reabsorb the fluid and the electrolytes, and hypovolemia can quickly occur. Ischemia and necrosis of the intestinal wall can cause a decrease in innervation and a cessation of peristalsis. A decrease in bowel sounds can indicate this change. Paralytic ileus will occur if it's not a cause to begin with. The obstruction promotes rapid reproduction of intestinal bacteria, some of which produce endotoxins. The affected intestinal wall can become necrotic, more permeable. This intestinal bacteria or toxins can now leak into the peritoneal area, causing peritonitis or the blood supply, bacteremia, and septicemia. The perforation of the necrotic segment can occur, leading to generalized peritonitis. Functional obstruction or paralytic ileus usually comes from neurological impairment. Peristalsis ceases and distension of the intestines occurs as the fluid and electrolytes accumulate in the intestine. In this type of obstruction, we might have reflex spasms of the intestinal muscle. In this type of obstruction, reflex spasms of the intestinal muscle do not occur, but the remainder of the process is similar to that of mechanical obstruction after abdominal surgery when anesthesia, inflammation, or ischemia in the operative area affects the conduction of the nerve impulses. This can happen. So functional obstruction caused because the area is not being innervated properly. Or the initial stage of the spinal cord injury when it's in spinal shock. Again, it might not initiate the response. Inflammation related to severe ischemia, pancreatitis, peritonitis, or infection, and then hypokalemia, mesenteric thrombus, or toxemia can all cause functional obstruction of the intestines. The colon, I should say. Mechanical obstruction can result from adhesions, hernias, scar tissue, any sort of mass or tumor, intussusception, which is actually telescoping of the bowel. So the bowel telescopes within itself. A volvulus, which is a twisting of the intestinal walls. They can also develop Hirschsprung's disease, which is a type of congenital megacolon. So the colon is enlarged here, and they lack parasympathetic innervation from that part of the colon. So motility is impaired here, and that'll cause constipation and eventually obstruction. And then gradual obstruction from chronic inflammatory conditions like Crohn's or diverticulitis. So these are all intestinal obstructions, okay? Mechanical, we just talked about all those ones. Okay, what mechanical, we usually have that severe colicky type of pain, intermittent bowel sounds. Paralytic ileus, the pain is steady and the bowel sounds are severely decreased or absence. Vomiting and abdominal distension can occur quickly with obstruction of the small intestine. The vomiting is recurrent and eventually with bile-stained content, or it might even have that fecal matter. And then obstruction of the small intestines is considered a medical emergency. So again, if they do have an obstruction like this, they can develop shock, okay, hypovolemic shock. So you're also going to monitor for that, like signs of dehydration, weakness, confusion. Obstruction of the large intestines develops slowly with mild symptoms, constipation, and mild lower abdominal pain, followed by abdominal distension, anorexia, and eventually vomiting and more severe pain. All right, so that's just going through the steps of it for you. We have the site of obstruction there. We have an increase in fluid and gas that causes distension now. Distension causes increased peristalsis to force the contents past the obstruction. And that's what causes that colicky pain. And then severe vomiting from the distension and pain can lead to dehydration and electrolyte imbalances. Increased pressure in the wall can cause more fluid to enter the intestines. We can have a decrease in the blood pressure. We can develop hypovolemia with third spacing. Continued pressure on the intestinal walls can lead to edema and ischemia and decreased peristalsis. And then prolonged ischemia can cause increased permeability, necrosis of the wall, intestinal bacteria, peritonitis. All right, with peritonitis, we have inflammation of the peritoneal membrane. It can be chemical, okay? Chemicals from like enzymes being released because of necrosis. Urine from a ruptured bladder that's leaking. Chyme that's spilled from some perforated ulcer. Bile escaping from a ruptured gallbladder. Blood or any other foreign material in the cavity. So we have inflammation of the peritoneal membranes. This can be from those chemical irritants, bile, chyme, foreign objects. This increases the permeability, allowing bacteria to go over the membrane or through the membrane and enter that peritoneal area. And that's going to cause necrosis or perforation of the intestinal wall. So inflammation in the abdominal cavity, the peritoneum, the omentum produce a thick, sticky exudate, and that allows the tissues to stick together and seal the area off. Local inflammation can cause a problem with peristalsis. Toxins can be spread here. Abdominal distension, and they'll have a typical board-like abdomen, which develops as the reflex abdominal muscle spasm occurs. They can have increases in vasodilation, increased permeability. Membrane can become edematous and red and leaky. Hypovolemia occurs here. We'll also have protein, fluid, and electrolytes secreted in that peritoneal area. So the body is not able to use them if they're in that peritoneal area. So that's going to affect other processes in the body. So peritonitis can also be secondary from trauma, ruptured appendix, pelvic inflammatory disease, abdominal surgery. I would know those. They like to ask about this. Remember, chemical is going to be from the enzymes released. Okay. Abdominal surgery from infection. Pelvic is from infection, and the infection spreads up the uterus, up the fallopian tubes, and into the peritoneal cavity. So peritonitis in general, signs are going to be sudden, severe, generalized abdominal pain, localized tenderness at the site, vomiting, dehydration, hypovolemia, all the things that go with dehydration. Decreased skin turgor, dry mucosa, pallor, low blood pressure, agitation, tachycardia, fever, leukocytosis, abdominal distension with that rigid abdomen. Decreased bowel sounds, paralytic ileus. That was it. Oh my goodness, we got through it. That was a big chapter. Any questions?
Yes, it was. A lot of information.
A lot of information, okay? Focus on those specific hormones that are being released and what they do. And then you should know like your basic signs and symptoms of things like peritonitis. You should know the difference in Crohn's versus ulcerative colitis. What is celiac disease? What causes it? What does it look like? So those are the things they're going to ask you about. And
Okay.
then play the video back over. I'm going to post this. Play it back
Okay.
over. What they say, you got to know.
Sounds good.
Play that Jeopardy game. I sent you that Jeopardy game today so that you can learn the terminology.
Okay.
Thank you.
All right?
Thank
All right.
you.
Thank you. So I need to
All
talk
right.
to you. So
Okay, hold on. Let me stop the recording.